this time to look back at what we have done earlier. So every session has a IFICS quiz, and Swapnil Kenny and his team prepares this quiz. This is known as Inquisitive. So I would request Dr. Avisha this time, a young pediatric orthopedic surgeon from Mumbai, to take us through the results of the last weekend's IFICS quiz and tell us how we have fared, the delegates, how they have done as delegates, and faculty, how they have done as faculty. So Avi, please share your screen and start.
Oh, oops. Sorry about that.
So Avi and Mandar will be sharing because they were the two young men of the last two sessions. So Avi would start and Mandar would take over, and Taral sir also has had some very interesting questions. The sir also will contribute. Go ahead, Avi.
Thank you so much, everyone. So let's get started with the quiz. We had about 103 people who logged in and responded to the quiz. So let's look at now how they did. So this was the first question. This was the X-ray we sent out to our delegates, and we asked a few questions regarding this. So the first question was that this was a 12-year-old female with a road traffic injury, and that was the injury which she suffered. And what is the most commonest complication which they would think that would occur and that they would advise the family? And the answer is physeal growth disturbance. 87% of the delegates answered this right, but still a few people said about non-union and other answers. Then the second question which followed for the same image was describe the type of the injury. Happy enough, 92% answered that this is a Salter-Harris type 2, but we still have people answering as this is a Salter-Harris type 3, that is 5%, and 1% saying it is type 1 and type 4. Then we asked them what was the most appropriate treatment they would do for the case which was given above. 83% answered gave a right answer, that is give an accurate reduction, either open or closed, and treat with a transmetaphyseal screw. But we still have some people, 6 to 8% answering otherwise. So the next set of questions, this was a lateral X-ray which we showed our delegates. And the question was, this is a 12-year-old boy who came with an ankle fracture, underwent a closed reduction under sedation in the emergency room, had a couple of attempts. The X-ray which was put up was after the attempts. So what would be the next line of management for this child? So the correct answer was open reduction, extraction of any interposition of the periosteum, and smooth wire fixation, which to decrease the displacement. So 69%, that is about 70%, gave the right answer. We still had about 30% who gave a different answer, and hopefully they will go back to the treasury and see why. These are the other set of X-rays which we sent. So this was an MRI of an older boy who had suffered an injury 2 years back and had a deformity at his ankle. So he's a 12-year-old boy who had a Salter-Harris type 4 fracture 2 years back, now presents to you with the current situation, has a 30-degree varus deformity at his ankle. So we asked the delegates what would be the best treatment plan. So 69, that is about 70% of our delegates answered correctly. That is, the answer would be corrective osteotomy with a physeal bridge resection, fat interposition through the through the osteotomy. So basically, as we discussed in the lecture the other day, because the distal tibia does not have enough growth remaining, so it is highly unlikely that just with your bar resection the deformity will be corrected. Hence, you need to add a corrective osteotomy. And usually the degree of corrective osteotomy for especially areas near the ankle, the acceptable is only 5 to 10 degrees. Anything above 10, usually a concomitant osteotomy is added. So these are another set of X-rays which we showed of a distal femur physeal injury to our delegates, which was already treated. So this was a 13-year-old male who had this fracture, was treated in a rural hospital somewhere else. Now the parents have come to you for a second opinion after 5 weeks, and the last injury was of the injury of the child in the cast. So we asked, what would you counsel the parents? What would be the long-term problems that this child could face? And the correct answer, 86% gave the correct answer, that is physeal arrest and limb shortening and angular deformity. The arterial injury is usually seen only in the acute injury, not at 5 weeks. Acceleration is very rarely seen in this type of injury, and we do not see recurrent fractures. Then we asked them, what is the earliest radiological sign of growth arrest? And the correct answer 80% gave, which is asymmetry of the Harris lines. The rest answered sclerotic bone bridge, but usually that is seen once the bridge has already formed. The next is the amount of leg length discrepancy after complete physeal arrest depends on, and the 89 to 90% have given the correct answer. That is both A and B. That is the contribution of the growth of that particular physis as well as the amount of growth remaining is important in determining the leg length discrepancy. The next is, what are the prerequisites for bar excision, and prerequisite for physeal bar excision does not include. So the correct answer is more than 20 degrees deformity. So the prerequisite is mainly you require at least 2 years of growth remaining and up to at least 25 to 30% of the physis which is involved, and at least the rest of the physis should be capable of having growth potential. The next is, what is the interposition material after physeal arrest does not include. So 70% gave the right answer, that is allograft. But unfortunately, a lot of people told fibrin glue, gluteal fat, and cranioplast are not used, but they are the main interposition materials which we actually used. Next, we'll talk about the supracondylar humerus fractures. Can get Dr. Mandar to add in.
Mandar, please.
Yeah. Yeah. So these are the next set of questions, the 10 questions for supracondylar humerus fractures. So the first question was about the medial spike of less than that degrees has higher chance of open reduction and complications. And this was the case which I presented. It's 45 degrees. Most of them, about 58%, gave the right answer. The next question. So which approach for open reduction has the highest chance of stiffness? It is good that almost 90% gave the right answer of posterior. Next. This was what was explained very well by Professor Melman. Which type of supracondylar humerus displacement has the highest chance of neurovascular compromise? It is the posterolateral one. Almost 60% could answer correctly. Now this was the X-ray which was given a very occult sign. Next. This elbow X-ray of a 6-year-old child with elbow trauma, which of the following is wrong? So the presence of an anterior fat pad sign indicates an occult fracture. So it's basically a posterior fat pad which is more significant. However, this was a very slightly confusing question, and almost 50% have answered wrongly. Next. So which of the following are not disturbed in supracondylar fracture? Anterior humeral line and Bowman's angle are very important. They're always disturbed. Radiocapitellar line is not disturbed. Almost everyone answered correctly. Next. So this is an X-ray which has some varus impaction, a very good X-ray. Next question. So this child has significant swelling and has the following X-ray with a hyperextension of 25 degrees and a Bowman's angle of 80. The most appropriate treatment, almost everyone, almost 70% have answered correctly. This requires reduction and pinning, a close reduction and pinning. Next. 8-year-old develops clawing after cross pinning. A diagnosis of post-operative ulnar nerve palsy is made. The most operative treatment is removal of pin and add another lateral pin if unstable. This again, almost 80% have answered correctly. Next. The pink pulseless supracondylar, the excellent lecture by Professor Melman. Supracondylar fractures, following actions are not appropriate. Thankfully, everyone has, almost 75% have told not taking consent for exploration in case the pink pulseless hand also has a pointing index. So that's an important point that almost everyone has answered. Next. In malunited supracondylar fractures, all the following required corrective osteotomy except, again, restriction of 10 degrees of terminal elbow flexion is not an indication for corrective osteotomy. Again, almost 100% of them have answered correctly. And we have the last question, an excellent question. Hobbies of international faculty in IFICS 2020 does not include carpentry, thankfully, though orthopedics is a form of carpentry. Thank you so much.
Thank you, Bandar. And just a couple of reminders. Whoever needs the certificates for IFICS has to attend the quiz. It is very important. The quiz will be sent to you on either Monday or Tuesday, and you need to answer it at least by Friday morning so that we can have the results and we can discuss them here. Thank you very much, Taral sir, Bandar and Avi. And we now transfer the proceedings for the meeting.
Thank you.
Absolutely. So good evening, everybody. It's 6:26. We have to start the proceedings at 6:30. So I welcome Dr. Sheetal Parikh here. Sheetal, please show a video so everyone can see you. Professor Wilkins is here. We have today's international faculty, Rroger and Eric. Everybody is present here. And almost 180 delegates have already logged in to this webinar. We have almost 500 registrations for this webinar, which started last week and is going to go through entire month of September. One fracture a day, that's the theme of this webinar. So I'm going to share the screen for people to know who the faculty are. And I'm going to start with myself. My name is Dr. Taral Nagda, and you can see my photo here. So I'm one of the three people, Sandeep Patwardhan, Premal Naik, and me, which started this IFICS Foundation, joined by Sheetal Parikh. And we had our first meeting in 2014 at Hinduja Hospital in Bombay. So I'm a pediatric orthopedic surgeon, and I'm also interested in cerebral palsy. Apart from pediatric orthopedics, what I do is that I like growing things. I'm an organic farmer, and you can see this boat at my farmhouse, which is around 180 kilometers from Bombay. I'm a gadget freak, webmaster for POSI, and what you can see here is Pangong Lake. It is in news for the wrong reasons nowadays, but me doing a yoga posture at the Pangong Lake, and also it says that I love to travel. So with this, I want to hand over introduction of the foreign faculty to Sheetal Parikh, the person behind IFICS 2020, the man behind the mission. Sheetal, could you please take over and introduce the two international faculty?
Sure. Yeah. Good morning, everyone, and good evening in India. I'm Sheetal Parikh. I don't deserve any credit. You already heard the three people who started IFICS. I was just supporting them. So I'd like to introduce our first faculty, Cornwall, Rroger Cornwall. He is from Cincinnati Children's Hospital. He's a professor of orthopedic surgery and developmental biology. He's the director of the Pediatric Hand and Upper Extremity Surgery Fellowship. I've known him now for quite some time, and he came to us from CHOP. And besides being an orthopedic surgeon, he's one of the few that you can truly say are the physician scientist. He has his own lab. He received NIH funding, which kind of validates his research, which is on brachial plexus. So we are very fortunate to have him with us today and as part of our department at Children's. You know, prior to him, we all took care of hand injuries, but it was the same concept that we all have. It's like, it's just a hand or it's just a finger. And then we learned a lot, what can go wrong and what we need to be aware of. He is interested, sometimes some of the Indian Bollywood, like hard metal music, he actually was showing it to me. So he knows more about music, even about Indian music, likes to climb mountains, run ultra marathons. He's a gymnast. He had an incident in the past, but that hasn't stopped him from gymnastics. And he has 5 boys that kind of keeps him busy. So thank you, Rroger, for joining today.
He's also written this wonderful book called The Door Is Not Locked. So we're going to learn philosophy apart from pediatric orthopedics from you, Rroger, and then second faculty. Sheetal, please introduce.
Yeah, so Eric Edmonds, he comes to us from San Diego. He's a professor of clinical orthopedic surgery, director of orthopedic research, and director of 360 Sports Medicine. We have, I've known him for a while. He's a great research person as well as a clinician. We have shared our few projects together, and I would like to introduce him to this program as well. So welcome, Eric.
So
Besides
what he does,
pediatric orthopedics, he likes to do backpacking, birding, nature and wildlife photography. Great interest.
So I'm going to introduce the national faculty, and top of the list we have Dr. Manoj Padman, who did his pediatric orthopedic fellowship in UK and then came to India, to the capital of India, New Delhi, and he is director of the Center for Pediatric Orthopedics and Disabilities. And he is consultant at Rainbow Children Hospital, Fortis Memorial Research Hospital, and Manipal Hospital. Then we have from Jaipur, the Pink City, Kapil Gangwal, who is at Santopa Durlabji Memorial Hospital. And besides being a full-time pediatric orthopedic surgeon and a part-time husband, he is also interested in cycling, trekking. And you can see from this photograph, he is an occasional photographer, but a very good photographer. We have Dr. Gaurav Gupta, again from New Delhi, who has recently passed his fellowship and has number of publications now. And he has a strong mental base and plays chess, cricket, and cooking, the 3 C's of his life, which are very, very important to him. Ashish Ranade is from Pune, the city of Peshwas, and he likes badminton. Like Sandeep, he likes badminton and he likes running. And he manages this in the traffic of Pune, which is very creditable to him. Our next faculty is Chasnal Rathod, who is a young pediatric orthopedic surgeon attached to SRCC Children Hospital. She is interested in neuromuscular problems, including cerebral palsy and upper limb. And you'll be surprised to know what she does besides pediatric orthopedics. She does Formula 4 racing, interested in trekking, and she runs marathon. And there are some people who also run behind her, besides her, and in front of her. So this is IFICS 2020, and we are on to the third session of IFICS. And the first part of this is going to be the lateral condyle fracture. I invite Rroger to start his presentation, share your slides, and start your talk on lateral condyle fractures in children.
Great. Thank you very much for that introduction. And you didn't need to bring up that book about finding happiness. But yes, I think it's great to talk about what we like to do in our lives outside of work, because even though we really enjoy what we do for our work, it's important to enjoy the rest of life as well. So I applaud the meeting organizers for including that in the introductions of the faculty. We need to do that more often in our meetings back home here. So good morning, good evening, good night, or whatever time of the day it is to people around the world. This hopefully will be a helpful session on lateral humeral condyle fractures and some other injuries. I have no relevant disclosures, although I do need to disclose that we just released the first book on pediatrics, strictly on pediatric hand trauma. So as Dr. Parikh mentioned, it's just a finger is a very common phrase that I hear, but that's not actually true. There are a lot of very difficult injuries that can occur in the child's hand. And so the Hand Society, the American Society for Surgery of the Hand, has just released a book on pediatric hand trauma that we put together with 40+ authors. I get no money from this book whatsoever, but I think it's just a very valuable resource for trainees, for even pediatricians, for emergency department physicians, all the way up through pediatric hand specialists. It goes from very basic to very advanced. So it's available at ASSH.org. And again, I make no money from this, but it can help you take care of pediatric hand injury. So the outline for this morning's talk or this evening's talk will be discussing the injury, discussing the evaluation of the injury treatment, but importantly also discussing many of the complications that can occur with this fracture, because it is a type of fracture that does tend to lead to several problems. And I got a sneak peek at some of the cases that we'll be discussing afterwards that very nicely demonstrate many of the problems that can occur, as well as some of the very elegant solutions that can be applied. And and so there's definitely a wealth of experience among the rest of the people on the panel, internationally and within India, and I'm sure a wealth of experience among the attendees, the delegates. But I'll give you my a basic overview and then my own point of view. So lateral condyle fractures account for about 10 to 15% of all pediatric elbow fractures. They can occur at any age, but most commonly between 6 and 10 years of age. They typically result from a fall on an outstretched hand or with a valgus stress, producing an intra-articular and transphyseal fracture. And those two components are important to keep in mind. It has been historically classified by the Milch classification, which talks about the direction of the fracture line through the capitellar ossific nucleus or not, but that doesn't really help guide treatment. Whereas the Jakob classification tends to, where type 1 is a non-displaced fracture, type 2 is displaced more than 2 millimeters, but with an intact cartilage hinge. And I don't love this particular version of the image because type 2 shows that the cartilage is violated. And I'm sure others have found a better image of this, a better illustration of a type 2. But then a type 3 is displaced completely, and that involves rotation of the fragment, which I'll demonstrate later is a very important component of the displacement. In evaluating these fractures, it's important to keep in mind the mechanism of injury, which can also help you elucidate other concomitant injuries. On the physical exam, I think it's important to assess the amount of swelling. I don't have a good clinical picture of it, but you can see on this radiograph that there's quite a bit of lateral swelling there. And if you have an X-ray that shows something that doesn't look awfully displaced or it's a little bit hard to sort out, your clinical suspicion of a severe injury can be, based on the swelling, can be very, very helpful. Location of tenderness can help you sort out other injuries as well as deformity for concomitant injuries such as a concomitant elbow dislocation, which can occur. And then range of motion should be assessed because that can help you sort out articular alignment and also can be very helpful in determining treatment of complications, as I'll talk about in a little bit. Radiographs typically display the fracture. You see a very subtle Thurston-Holland fragment, typically just above the capitellar physis on the AP view. And you can see it on the lateral as well, although the internal rotation oblique, I find, and many others have found, and it's been shown in literature to be the best view to fully visualize the fracture. And so this is an AP view of the humerus with a little bit of elbow flexion where the shoulder is then internally rotated about 45 degrees. And if your radiographers are similar to ours, and by ours I mean both in Cincinnati and at CHOP when I was there, and sometimes get confused which is an internal rotation oblique versus an external rotation oblique. Are you referring to the elbow or the tube? It's helpful just to get two obliques of the elbow and one of them will be right. And so that can be very helpful in assessing fracture presence and fracture displacement. Advanced imaging can be sometimes necessary. An MRI can demonstrate an intact cartilage hinge. It can also help you assess displacement, but it requires anesthesia or sedation in young children. Whereas an arthrogram, which is typically done in the operating room, can also show you the articular surface really quite nicely. And in deciding between the two, it's important to keep in mind what's available, and you might not have an MRI available, so an arthrogram can be very helpful. But where you have availability of both, what I like to use to help me decide is whether or not I think they're going to need an operation. And so if I'm almost certain they're not going to need an operation, I just want to be sure, then an MRI can be a helpful way to rule that out. If I'm pretty sure they might need an operation, then I'll take them to the operating room to confirm it with an arthrogram, because then I'm already in the place where I can fix it if I need to fix it. It's important to keep in mind the differential diagnosis, which includes a supracondylar humerus fracture, which will have associated medial tenderness and of course a transverse fracture line, as well as a radial head and neck fracture, which can also give you lateral elbow pain and swelling. This really only comes to play when the radiographs are fairly subtle. Usually when you have an obvious lateral condyle fracture, you don't have an associated radial neck fracture. But when it is subtle, the location of tenderness can help differentiate, as well as pain with forearm rotation, which is typically more pronounced with a radial neck fracture. In treating these fractures, I think it's very important to keep in mind the problems that can occur, because your treatment is really designed to avoid the problems that occur with this fracture. And so these problems involve the elbow joint, where you can have articular cartilage step-off, which, as we know, will potentially lead to joint arthrosis. But also it's very important to keep in mind a collinearity of the condyles. So if you imagine the elbow like a door with two hinges, if those two hinges line up perfectly, the door will open and close. However, if one of those hinges is out of line just by a centimeter or two, the door won't move. And so the two hinges of the elbow are the ulnotrochlear joint and the radiocapitellar joint. And if the lateral condyle or the capitellum is out of line with the trochlea, then that can have a profound effect on elbow motion, even if the articular step-off is minimal. Also, because the fracture crosses the physis, a growth arrest can occur. And because the lateral ulnar collateral ligament and the extensor muscles originate from the lateral condyle fragment, there are substantial deforming forces pulling the fracture into distraction or anterior translation, really nothing pulling it backwards, inherently keeping it stable. And either because it's an articular fracture or for other reasons, such as the traction on the fracture site, fracture healing is slow. And so it doesn't heal as rapidly as a supracondylar fracture. And so the complications such as late displacement that can occur over a longer period of time. And so really the goals of treatment are to assure anatomic alignment and stability until healing, right? And so for a non-displaced fracture, it's actually fairly straightforward. You can treat it in a cast like many non-displaced fractures. However, about 10% of these will displace. And in one study, demonstrated that all of that displacement occurs within 5 days after the injury, but actually it can occur later. And so I think it's important to get weekly radiographs to check for displacement, at least for the first 2 to maybe even 3 weeks. And it's important to get these x-rays out of the cast. Again, this Thurston-Holland fragment is fairly subtle. And so when you have a cast on, not only is the elbow flexed, and so an AP view is difficult to interpret, but when the plaster or fiberglass is overlying the fracture site, it's actually difficult to see the fracture site, and that can it can actually make it look like it's displacing more just because of the artifact. And so radiographs out of the cast can be very helpful to assess displacement, such as you can see occurring here. And it's important to keep in mind the length of time to healing. It can be 6 weeks or longer. It's not just the 3 weeks that you have for a supracondylar fracture. And because late displacement can occur, it's important to keep the cast on until you're fully convinced that that fracture is healed. For displaced fractures, there are 2 independent steps for treatment. One is getting the reduction, which can be open or closed. And the second is maintaining the reduction. And because this is an inherently unstable fracture, as I've mentioned, we're talking about fixation rather than cast type. And it's important to think of these 2 independently, because you can do the reduction open percutaneously or closed, or you can use pins or screws with either version of reduction. And so think about achieving each goal independently. So for reduction, closed reduction is certainly possible, although I will submit that an arthrogram, I think, is required to assess the unossified articular surface. The lateral cortex of that Thurston-Holland fragment can be very deceiving. It can be lined up perfectly, but you can have a very displaced fracture still, and I'll show a couple examples of that. I'm a strong proponent of a posterior approach to the arthrogram. It's extremely easy. Just pop the needle into the olecranon fossa, just right through the middle of the triceps, right down to bone. Be careful there isn't a patent fossa there, and it'll go through the bone into the front of the elbow. But just put it right down to the bone and inject, and you'll fill the elbow joint. The reason I like it, not only is it very easy to get in, it's a lot easier to find than the radiocapitellar interval, especially in a setting of a lateral condyle fracture with a lot of lateral soft tissue swelling. But if you miss somehow and you inject the dye extracapsularly, that cloud of dye will be posterior to the humerus on the lateral view, so it won't obscure the articular surface when you finally get a good arthrogram. And it will be superior to the articular surface or proximal to the articular surface on the AP view. So again, it won't obscure it once you finally get a good arthrogram. However, from a lateral approach, if you miss and it ends up in the lateral soft tissues, it will completely obscure the articular surface on the lateral view thereafter, and you will never be able to see that lateral view until that dye has fully dissipated. So that only has to happen once before you realize that that can be a real problem. Advantages of closed reduction, obviously, is that you don't require an open approach, so it's quick and easy and minimally invasive. However, there are some disadvantages. You cannot visualize the articular surface 3-dimensionally. Even a very good arthrogram can't give you a good 3-dimensional view of the articular surface. and you have limited ability to see or control the fragment. The Thorson-Holland fragment is very small and can be difficult to see even after an orthogram. And so it's not impossible to put your screw or pins in the wrong place, as was done in this fracture, fixed by a very good surgeon. And so it's not advisable for severely displaced fractures. I'm sure there are some reports. I know there are some reports out there that discuss using closed reduction and percutaneous fixation for severely displaced fractures, showing good results in the hands of the authors who have done that technique and published the series. But that's really in the best of hands for people who are really adept at that maneuver. And I'm sure there are some cricket bowlers out there that are able to hit the stumps blindfolded, but because just they know the pitch well enough. But that doesn't mean it's advisable for everyone to try that. So I'm a big proponent of open reduction for the severely displaced fractures, because you can visualize the articular surface, although it's important to keep in mind that the fracture line can really go quite far medially, and so you really need to be able to see the distal articular surface, and you may need a little bit more of an approach than you think. You have an ability to directly control the fragment, and therefore it is suitable for the severely displaced fractures. However, of course, there are disadvantages associated with an open exposure. It takes longer and there's a scar. And there is a risk of avascular necrosis, especially from posterior exposure of the fracture fragment where the blood supply is coming in posteriorly to the capitellum. So that should be avoided. These two have been compared in a retrospective study of the 2 to 5 millimeter displacement, that gray area where both techniques can be done, with 51 open reductions and 23 closed reductions, where of course surgical time was faster with closed reduction, and there was one case of ABN in the ORAF group, and so overall there was no difference in outcomes. And so I think for the minimally displaced fractures, either one is reasonable. Moving on to fixation, regardless of how you get the fracture reduced, either open or closed, then you have to fix the fracture. And so there are two types of fixation most widely used. The first is pin fixation using 2 or 3 smooth pins. There are, of course, advantages. There's no open approach required. The pins are temporary because they're left percutaneously. You don't need surgery to remove them. However, there are some distinct disadvantages as well. First, you don't get compression at the fracture site with the pins. With a screw, you can compress a fracture, but with pins, they can hold the fracture in place if you've compressed it in your manual reduction, but they don't themselves give you compression. And because they're percutaneous, there is an infection risk. And sometimes you find that you need to pull the pins either because they are infected or you're worried that they're becoming infected even before the fracture is healed. Remember, this is a slow healing fracture. And so if you have to take your pins out at 4 weeks and it's still not healed, you can end up with a non-union and further displacement of your fracture, even after you've operated on it, and then you're right back to where you started. And in my practice, that only had to happen once for me to decide I was going to move to screws instead. And so advantages of screw fixation are that you get compression at the fracture site, which helps with both stability and healing. It can be done with a percutaneous approach. All you need is the wound large enough to get the washer in if you're using a washer. And then because the screw is left inside and not percutaneously, you can leave it in until complete fracture healing. And also there's minimal infection risk because it's not percutaneous. The opponents of screw fixation will say that it requires a second surgery to remove them, although I'll note that I've had a couple of folks come back actually to be clear to join the military or to get their screw out so they can join the military, which seems to be a requirement in our military in our country, where the screw has never been removed and is now completely encased in the bone and they have no trouble at all. So it's questionable whether or not you actually do need to remove the screw. But you do have to be okay with a weird looking x-ray where, because there's still cartilage on that fragment, when you get compression and it's even countersunk into the bone, it still looks like it's sticking out, like you didn't really tighten the screw all the way. So if you're okay with that, screws can work really well. There have been several underpowered retrospective studies, classic orthopedic literature saying that there's no difference in complications without really being able to say that statistically. But there are a couple of studies that did have sufficient power to compare these two techniques. One comparing 43 pins with 41 screws, where there were 3 non-unions with the pins and none with the screws, and a faster return to range of motion and function when screws were used. And in the esteemed Indian Journal of Orthopaedics, 20 pins compared to 22 screws also found better range of motion, carrying angle, and faster recovery when screws were used. Yet, very recently, a prospective study of just pin fixation found that about 10% had delayed union requiring screw fixation and/or a pin tract infection. So just like my case shown below, it's still here in 10%, in case after case, as we say, that you have this complication occurring, yet the authors still recommend pin fixation. So with all that taken into account, my preference for non-displaced fractures, as I mentioned before, is a cast, but with weekly radiographs out of the cast for 2 to 3 weeks, with the cast until fracture healing documented by bridging callus. That's obvious, not just a little bit of callus starting to form, because you can see that on your way to a non-union, and they're non-tender at the fracture site. For minimally displaced fractures, or those with no or minimal articular translation, a percutaneous reduction and screw fixation with an arthrogram. And for more displaced fractures where their displacement includes articular translation or rotation, I prefer open reduction and screw fixation. I have done this with closed reduction, but I advocate open reduction, especially if you're not extremely facile with closed reduction and arthrograms. And really all of the treatment that we're providing is trying to avoid the complications that can occur. And those complications are really quite varied. First, as I've mentioned a couple of times now, slow healing and late displacement can occur, but we know that fixation can be performed later. Again, a very good study of 21 late presenting fractures showed that treatment was possible, but that the clinical results worsened as the delay to surgery increased, and that was measured in weeks. And so I'd rather fix a fracture at 3 weeks that's displacing than fix a fracture at 10 weeks that has displaced and not united. Redisplacement could even occur after surgery. Again, as I mentioned, difficult visualization using a closed approach can lead to putting a screw in the wrong place. Here are 2 examples of that by 2 very good surgeons that led to redisplacement and need for further surgery. Non-union can certainly occur either because of late presentation or inadequate treatment. It usually involves about 1 to 2% of fractures that are typically displaced fractures to begin with. And my preference is for fixation in situ using bone graft. And you'd be surprised if you haven't seen this before, that the range of motion can actually be quite good in the setting of a non-union. It's different from a malunion because there seems to be some flexibility in this very slow displacement of the fracture that allows remodeling of the articular surfaces. The range of motion can be quite good, so that you don't need to actually reduce the fracture if they have good range of motion to begin with. There are a number of different techniques of vascularized graft that can be used for non-union, although I haven't had to do that in any of the patients that I've treated. An osteotomy can be performed concurrently or subsequently if there's an associated cubitus valgus deformity. And there are a number of small series of a number of different techniques all showing reasonably good results. Malunion is a different problem though, and this is usually a result of inadequate diagnosis or inadequate exposure and reduction. So here's a really good example of a closed reduction in percutaneous pinning of a lateral condyle fracture where the surgeon was convinced that the reduction was anatomic because of anatomic alignment of the posterolateral cortex of the Thurston-Holland fragment, as you can see at the arrow. That is absolutely perfect. Yet there's a complete articular disruption with loss of collinearity and a very large articular gap at the articular surface that required an osteotomy. Here's another case, again, closed reduction percutaneous pinning with perfect alignment of that lateral column on the plane radiographs with a 90-degree rotational deformity through the middle of the articular surface. You've got an AP of the humerus and a lateral of the forearm because the lateral condyle is internally rotated 90 degrees and pinned like that. So that's a real problem. Of course, again, needed an osteotomy through the articular surface. And this has been reported in Boston. And when I had my first example of this, I called Peter Waters, where I did my fellowship, and I asked him what he thought and what he should do. And he said, yeah, you need to do an osteotomy. And I said, well, have you done it? He said, yeah, I've done about half a dozen of them. And I said, well, how do they turn out? They said, well, about half of them turned out really well. And the other half, I'd rather have stuck a hot poker in my eye. And so I thought, okay, 50% hot poker rate. That's I can work with that. But the point is that even though you can treat these, it's much, much better to assure anatomic reduction the first time rather than get into a situation of a malunion. Growth arrest can occur as well, and up to 20% in some series, and it can be partial or complete, although surprisingly, I haven't seen any of these yet. in 17 years or so, but I'm sure they are out there. And then, of course, there's this lateral prominence that occurs, creating a bump, or a cosmetic, but no problem, but no functional consequences that have been documented. It can even occur in non-displaced fractures, and 9 studies demonstrating an incidence of anywhere from 10 to 100% obviously means that there's a discrepancy in what you constitute as a lateral bump as a complication. But it's easier to tell families that pretty much always you're going to get a lateral bump there from the fracture healing, much like we counsel families with mid-shaft clavicle fractures, that there will be a bump there that gets more subtle over time. So with that whirlwind tour, I hope I've been able to make a few points about lateral condyle fractures. First, don't underestimate the fracture. It's important to explain to the family from the beginning what all the problems are, because many times there'll be some level of familiarity with elbow fractures and you think they're going to be quick healers and no big deal. This one actually can be a big deal. It's important to ensure articular congruity and don't hesitate to use imaging or open reduction to make sure that you have articular congruity, and then make sure the fracture is fully healed before you stop your treatment. Being aware of all the complications can help you avoid them. And with that, I thank you for your attention and hope that this was helpful. Thank you very much.
So thanks, Rroger. That was a great talk. We are a big fan of Bollywood movies, and always there is a dialogue which says, "Don't underestimate the power of a small man, and don't underestimate the power of this small fracture to get a potential complication." Sheetal, you have any questions for Rroger before we go on to the cases?
Yeah, no, that was a great talk. I think it was a nice overview. I've got a couple of questions, Rroger. So, if we see all these complications, malunion, non-union, and if someone who is not treating more than 4 or 5 a year, do you think that an approach that if it's displaced, I'll just open and put a screw in, and so I don't have to deal with this malunion, with this, issue about whether the reduction is good or not, because, on the arthrogram, sometimes it can fool you. So if that approach, if someone says, if it's displaced, I'm not going to do anything, just open and put a screw in. Is that approach okay? Or you think that it should be graded, that, if it's displaced a little bit, you can do close reduction, put a screw or pin in. If it's displaced more, then I would do, screw, maybe because, with high volume, you get more confidence. But if you're just treating like 4 or 5 fractures a year, do you think that approach would be a okay approach to just open all of them?
Yeah, I think that's a fabulous approach. And I think it depends on comfort level and resources that you have available. And if really the goal is to get an anatomic articular surface. And if you think you can get away with it closed, then you're already starting to think down the wrong path. I think you have to be confident that the articular surface is intact. So opening it, yes, there are downsides to it, and yes, there's a risk of AVN if you go posteriorly. So don't go posteriorly. You're not going to see the articular surface anyway, because the olecranon's in the way in that regard. But as long as you don't go posteriorly, it is safer to open and get a good reduction than it is to try to do it closed and end up with a malunion. Great point.
And my second question, you brought up the question
So,
about...
Rroger, there are a couple of questions.
Go ahead, Sandeep.
Sorry, go ahead, Sheetal. So there are a lot of audience questions, and most of them wanted to know your approach for open reduction.
Okay, so so lateral approach along the lateral column is typically sufficient, and you can approach it many different ways, but just essentially taking the brachioradialis off the lateral ridge and then coming down anteriorly. And don't hesitate to, there's usually some capsular stripping there as well, so the approach is pretty straightforward from there. I don't routinely go out and dissect out the radial nerve, but it's very important to keep in mind that the radial nerve sits directly on the anterior capsule laterally there. And so heavy retraction can injure the radial nerve even before the PIN is coming off. And also keep in mind that that fracture line can go very far medially. And so unless you are sure that you see the articular surface, don't hesitate to make your exposure a little bit bigger, even more proximally, so you can reflect that anterior capsule further over. it's conceivable that a medial approach could be helpful as well if it's a very far medial fracture line.
Dr. Cornwall, there are a few people who wish to know whether can you prevent a lateral bump after open reduction?
Prevent a lateral bump?
Yeah.
Boy, I don't know.
And what is your take on OPD based sonography? How often do you advise sonography for your children with elbow injury?
Oh, ultrasound.
Yes.
Yes. So there are certain situations where I use it as my favorite. So anything dynamic. So this is way off topic, but valgus instability here in the United States, we don't play cricket, we play baseball. And so it's a very different pitching versus the bowling technique. And so we have a lot of valgus instability. So if you want to dynamically assess the elbow in stability, then you can use an ultrasound for that. If you are looking at fractures in the elbow, then you just have to keep in mind how shallow the penetration of an ultrasound is. In cartilage, it can penetrate a fair bit, but in bone, it only shows you the surface of the bone. And so you can identify or quantify surface displacement of a lateral condyle fracture. But again, I hope those images of the perfectly aligned surface cortex of the lateral column with complete malrotation of the lateral condyle will stick with you forever, because an ultrasound would show that alignment is perfect. So I think there are some roles for ultrasound, looking at the radiocapitellar joint, for instance, and looking for anything dynamic, but it can be very misleading in assessing bone alignment in this particular circumstance.
Okay, Dr. Cornwall, I think we'll go to cases and we'll have few more questions at the end of the session. We have lots of, we'll take it at the end of the session. Lateral, please go ahead with your cases.
Absolutely. So there are many questions which have come from the audience. So what are we going to do is include all the questions along with the cases in discussion. And there is a special session called Extra Time at end of this. So, all the delegates, be rest assured that most of your questions will be answered. So for the cases, I want to invite Kapil Gangwal first for a 3-year-old child with lateral condyle fracture. Kapil.
Sure, Taral, thanks. So this is a 3-year-old child who came with an elbow injury. And we can see that it's minimally kind of displaced fracture and swelling around the elbow. And I think if we take a closer look at the fracture, this was minimally displaced. It was treated in an above elbow cast by the treating surgeon at that point. So now we'll take our audience poll at this time. Error in management has been not doing a MRI or CT, not doing an arthrogram, not doing an internal rotation view, or not doing stress views. I think, are we going to go to the poll? Yeah.
So please start answering. All the audience panelists can also answer this. And we have around 5 seconds more. People have been really quick this time. Just in 10 seconds, I have 150 responses. So, Kapil, these are the responses, and what's your take?
Okay, fantastic. So I think everybody was awake in Rroger's talk. So the internal rotation view is probably the most important thing that one needs to remember in these fractures, and that really brings the fracture into profile because the fracture line goes from posterolateral to medial. So can we go to the next slide? Okay. So this is what it looks like when you do the internal rotation view. It really brings the fracture in profile, and in the vast majority of these cases, the fracture will look more displaced when you compare it to the anterior-posterior projection.
So one of the questions from audience today was, Rroger, how do you take an internal rotation view? How much rotation is required? Can you answer that?
Yeah, that's a great question. I was actually just thinking the same thing, because if you look at this example of an internal rotation view versus the one that I provided, which looked like just a really bad lateral, it can really vary, but you still get the same information. It's almost an X-ray that you can't do wrong unless you do an external rotation view. If you do an external rotation view, the fracture completely disappears. It looks like a completely normal elbow. but I don't think it really matters how much internal rotation you do, because you can still get a lot of information out of it.
So one of the ways I identify a good internal rotation view, if the ulna and the radius, they overlap onto each other. If you can see both separately, then the radiologist has not done a good job. So that's about internal rotation view. Let's go ahead. Yes, Kapil.
So the child was put into above elbow plaster, and then after a week, the child was called back to get another X-ray, and this is what it looked like at that point. And as we heard, that most of these unstable fractures will displace within 5 days. So it's important to really check the radiograph after 5 to 7 days. Okay,
Rroger had a very important suggestion that X-ray should be done out of plaster. So remove the plaster and then take the X-ray. If you take X-ray within the plaster, it has no meaning. So let's go back to audience poll again. And these are a few questions looking at the X-ray at 1 week. So, everybody, please. So I have no doubt. Plaster for 3 weeks, won't take a chance. I will do pinning in situ. I want to confirm and do an MRI, and I will think this is stable. I will take X-ray after 1 week and then decide. So these are the questions. And let's have the results of the audience poll. Yes, Kapil, what do you think?
Okay, so everybody thinks that the fracture has displaced a bit, and they would pin it in situ. The treating surgeon at that point hadn't attended the IFICS module, so he decided something else. Let's go to the next.
One question I want to ask Rroger is, how late can you pin? How late is too late to do pinning in situ?
Well, that's a tricky question for a couple of reasons. First of all, I don't love pinning, and second of all, we can do internal fixation in situ of a non-union that's been there for years. And so I don't know that there's really too late, but if you have a fracture that is displacing, it can be easier to get a good reduction before it displaces too far laterally. So your chances of being able to do a closed reduction diminish over time as the fracture displaces. So I don't know that there's a strict cutoff, and I should know the data a little bit better from the study that was published in the Indian Journal of Orthopaedics about late reduction and fixation. But as it got out to, I believe, about 8 to 10 weeks, the results really started to drop off. And I think it was mostly stiffness that was the problem in that. So I would rather fix these, at 3 weeks than here at 6 weeks, where now it's going to be a more difficult reduction.
Hey, Kapil, before we move on, Kapil and Taral. So I think that in situ fixation is not the ideal way to like if you have to make a comment, why won't you reduce and pin? Like in situ pinning, I would think would be when you have a non-union and you want to just put it right in that place, or you have severe deformity and you say that, I don't want to reduce it. That is in situ pinning. When you say in situ pinning, that means you're going to fix it in a displaced position. So I don't think that answer is correct on the poll. I think I would go with close reduction and pinning and not in situ pinning, unless you're saying in situ instead of, if you mean just closed by saying in situ. Otherwise, I would not fix it in the position of displacement. That is, if you go back to your previous X-ray where you did the poll, the fracture was displaced. So I don't think that's the correct option there. I would agree with fixation, but I would do it after close reduction.
Yes,
so
I agree completely.
The question is, at 3 weeks, you have displacement, and this is a time where a close reduction will not be possible. So will you go ahead and do an open reduction at 3 weeks? Or 4 weeks after the injury? What will you do?
Well, this is different from a supracondylar, which you can rely on some remodeling as long as your Bowman's angle and the anterior humeral line are okay. This is an intra-articular fracture. So if you do an arthrogram when you are in there and you say that there is a hinge and you pin it, then that's fine, But if you think that there is an articular surface displacement based on arthrogram, it doesn't matter what you have to do. If you have to open it, yes, you have to open it at 3 weeks and treat it. because that's not going to remodel on the articular surface.
Absolutely.
Rroger, what do you think?
I agree completely, and I think you bring up a very good point there that in situ pinning is really not the correct definition, because the point number one for treatment that I hope I made was ensure our anatomic articular alignment when you're treating the fracture. A non-union is completely separate when it's had years of remodeling, and you can only make it worse by changing it further. So, but there are different types of displacement that you'll see at 3 weeks. There's a type where it's just separating or hinging on that intact cartilage hinge, and a close reduction is possible if you use a screw, because as you put your screw in, it will close that down and compress it. Whereas if you have translation laterally, then at 3 weeks, it might be possible to do a closed reduction, but you have to be absolutely sure on your arthrogram that you've achieved an anatomic closed reduction before you accept it, or just open it at 3 weeks and reduce it. But yes, when you're treating an acute or subacute fracture, reduce the fracture and then fix it. Those are two separate steps.
Absolutely. So that's underlying the point for early diagnosis, because earlier you diagnose, it's possible to get this accurate reduction in a close manner. As you move along, the fracture is going to displace because of the force of the common extensor origin. And then something which was possible to do with a close reduction and pinning, you have to open and treat it. So let's see what happened to this patient.
So this is at 6 weeks, and the child came out of the cast, and that was the X-ray. The surgeon thought it had united because there was so much of callus on the posterior and the lateral side. So he just continued. He told them that you can start mobilizing and it's all okay. Well, this is 10 weeks post-injury. He still had some pain and stiffness. So they came back. This X-ray showed this picture. So I think we have our audience poll. Do we, Taral? Next slide. So how do we manage now? Close reduction and K-wire fixation, open reduction, internal fixation, open reduction, fixation, and bone grafting, or putting a screw in situ.
While we're answering this, I think it's important to underscore that statement that all of that callus does not mean union. So that was a point I kind of glossed over earlier, but there's definitely a lot of callus on the way to a non-union.
So audience is kind of a little mixed on open reduction and fixation and bone grafting, and 15% with in situ screw. So, well, let's go and see what was done. Next slide, Taral.
Yeah.
So this is, he had a reasonable range of motion, and so we decided to go ahead with a percutaneous screw fixation. And this was, we didn't make any attempt to open the fracture up. And this is how it was done. That's the reference for the technique that we adopted. So the prerequisites were range of motion within 20 degrees of normal side, and it shouldn't be a very long non-union, long-standing non-union, the ones which were less than 15 weeks from onset. That's about 6 weeks after fixation. And I think we have another follow-up. So that's about 3 months. And so the fracture went on to unite. He had a reasonably good range of motion. So learning points from this, X-ray and internal rotation is extremely important. We need to get follow-up X-rays out of the cast after 1 week, and minimally displaced lateral condyles, which are unstable, if not fixed, may go into delayed union or non-union. And early non-unions with good range of motion can be treated with in situ screw fixation.
So Kapil and Taral, I have a question for both of you, because you guys see more late presenting lateral condyle fractures. So in situ pinning, do you confirm with an arthrogram that the articular surface is okay, or if it's not okay, what do you accept? Like, as long as you said the motion is okay, you would just do in situ pinning even if there is a gap, which I think it might be okay. I just want to get your opinion.
So I don't do an arthrogram in these cases. What I'm aiming at is a metaphyseal union, and we let the articular incongruity be as it is. Because
as long as they have motion, you would just leave it the way it is. Taral, this is your experience as well?
Yeah, so range of movement is very, very important. And if they don't have a good range of movement, it means that there is articular step. And in that case, I would go down, open the fracture, align it well, and then fix it.
But you do not do an arthrogram for these late presenting?
So I do out of my curiosity because I want to see what is happening.
Okay.
But it has not changed the plan of management. If they have good range of movement, arthrogram finding is not going to change anything for these early non-movements.
And then does the screw have to be bicortical? Rroger, what is your experience? Like I saw the screw to be bicortical in Kapil's case. Does it have to be bicortical, or it could be just in the metaphysis?
Right. So I actually prefer it not to be bicortical. I try to get the screw threads to sit right in the V where the anterior and posterior cortices are coming together above the olecranon fossa. So if you can get the screw threads to sit right there, you get fixation on the sides. It's actually really dramatically good fixation. And in fact, I've stripped the threads off a Synthes screw by just turning it into that spot. I'm not a big fan of going all the way across, especially with threaded guide wires, because you're going from posterior to anterior as well as lateral to medial. And so you're aiming directly at the medial neurovascular bundle and the median nerve. And so I think that that going bicortical with a threaded guide wire, which can go much further than you think, you can't feel the far cortex, and putting the screw all the way across can have some problems.
So you would rather go tricortical than bicortical? Get the three cortices of just above the olecranon?
Well, not through the cortex into the olecranon fossa, but I would rather just
when you're saying three, you have three sides that you'll be touching.
Yes.
Is what I
mean. Yeah.
Perfect.
So let's go on to the next case. This is a young guy, 5-year-old child with this RAP and lateral. And as Rroger said, we took an internal rotation view. And let's go on to the audience poll here. How do you manage this question? Can you launch the audience poll, Ashok? Okay, so Rroger, what's your take on this? This is the X-ray.
Okay, I'm sorry. I was actually looking through some of the audience questions in the chat there, so we didn't miss any good points. Can you go back?
This is the internal rotation view. The fracture is just into a metaphysis, and the question is, how should you manage? Should you pin all undisplaced lateral condyle fractures, or there are some which you can conserve and treat in plaster? So what would you do for this fracture?
Yeah, so if the other views show that it's equally non-displaced as it looks on this view, I would put it in a cast and take the cast off in a week and take another X-ray. And as far as the position of
we put it in the plaster, took another X-ray, undisplaced. Yeah. So how do you give the plaster? What is the position of the plaster? Is it?
Yes, that was another question. So I don't know that the position of the cast or the position of the forearm in the cast and the wrist is going to really make the difference. In theory, you would take tension off the wrist extensors by putting the wrist in a little bit of extension, and you could put it in supination, but I don't know that that's really going to make the difference in what's going to displace or not. Probably what makes more of a difference is how far the fracture line goes through the cartilage towards the articular surface, and regardless of how you supinate and extend the wrist, it can displace.
So this is the X-ray at 4 weeks, and the question is, how long do you immobilize? Is it 3 weeks, 4 weeks, 6 weeks, 8 weeks, or till the time fracture heals up?
Until it's fully healed. And I think you have to use your clinical judgment here. You're pretty good at assessing fracture healing if you treat fractures, and you just have to know that this one can look like it's healing and not be healing, and just use your clinical judgment. If you still see a fracture line, especially the one that goes all the way out to that edge of the internal rotation view, then I would keep it in a cast.
Okay. So we did follow up till complete union, and he had 7 weeks of plaster. And you can see X-ray at 7 weeks; it's completely healed now. And it's very, very important that you don't be, judgmental about the duration of the plaster. It has to be immobilized till the time it heals, and a close watch is necessary. This is a 5-year-old. Yeah.
Taral, we have one question. What is the position
please.
of the forearm in the plaster? A relevant
Yeah,
question.
he answered that. Rroger answered that it doesn't matter, but generally I put it in supination with wrist in dorsiflexion, but we really don't know whether that matters or it doesn't matter. But just to neutralize the forces, we do it in that position. So this is a 5-year-old, and this is AP lateral and internal rotation view. And here, the question is, do you do MRI? You mentioned about higher investigation. So what are your indications for doing a higher investigation for a lateral condyle fracture? Do you do it for all the patients or selective patients? Which patients do you do? Or you don't do at all for any patient?
So in this fracture, and it's a little bit hard to see on the X-rays, but you start to think that the fracture line might be going all the way to the physis, but you still don't know if that fracture line goes through all of the unossified cartilage to the articular surface. And so again, on all 3 views, it looks non-displaced. And so I would just do the regular treatment. And if it looks like it's displacing in terms of gapping open or hinging open, then I would treat it. And if it looks like it's translating, then you have a better sense that there's not an intact articular hinge, because it can't translate or move sideways or laterally if there is an intact hinge. And then you need to fix it. And so I'll do an arthrogram in the operating room. The MRI is usually more reserved for fractures that are a little confusing, and fractures that I think are probably okay, but might not be. And so an MRI can be helpful there.
Absolutely. So this patient, we took again X-ray at 1 week. The parents refused MRI because that would necessitate anesthesia or sedation. And this patient, after 4 weeks, healed very well, and we kept him in plaster for another 2 weeks and then discharged him. This is a 4-year-old now with elbow trauma. You have AP and lateral, and then you have an internal rotation view. So any comments, Rroger, on this internal rotation view? Is this the fracture? Would you put it in plaster? Or so let's go to the audience first and then come back to Rroger. So everyone look at this patient's AP lateral and the internal rotation view, and you can see here the medial and the lateral gap. Both are wide and it's a parallel fracture line. So we want to know from our audience through the poll, what would you do for this fracture? Please launch the poll, poll number 5. So I'm going to give just 10 seconds for everyone to answer this. So please be quick with your hands. It's upper extremity session, and we really have to show our work with upper extremity. Okay. So, okay, won't take a chance. 75% feel that they would do pinning in situ. There are 5% who want to do an MR. Chetan, there are still people who want to confirm and do an MR on this fracture. And some people say that they will treat it in plaster and take X-ray after 1 more week to see what's happening. And there are 2%, we really have to felicitate these people who say, I have no doubt, I will still put this in plaster for 3 weeks. So Rroger, how would you treat this fracture? Do you agree with the audience or you don't agree?
So I actually agree with Sheetal that the answer that I would choose is not on that list, as he brought up earlier. So if you're going to fix it, you're going to fix it because it's not aligned properly. And if it's not aligned properly, then you need to reduce it, not just pin it in situ. So if you have, I don't know if you can go back to the original X-rays, but it looks like it had changed alignment. There was a set of X-rays before that? Or no, that was the original one. Yeah, so that one, it looks like there is some lateral translation at the physis, which indicates that there's probably some lateral translation at the articular surface. And so in this situation, and here I also want to bring up the point that I would actually call that lateral more of the internal rotation view that you want, where you can see the posterolateral part of the fracture line quite well. And so, internally, a lateral in internal rotation is an internal rotation oblique. So that can be very helpful as well. but yeah, I think you can see so there's some lateral translation of the fracture, and I would have taken this to the operating room. I would have done an ultrasound, and then I would have done a closed reduction and a screw fixation. So not pinning in situ, probably not an MRI.
But you meant an
Absolutely. So
arthrogram,
I would not do
a-
MRI for this patient because we are going to do arthrogram anyway. We are going to fix this patient. Yes, Sheetal, you had some points to make.
No, I wanted to bring Eric in just to get his opinion because I don't know if it's an institutional thing about getting MRIs or ultrasounds, and these are the fractures that that is difficult to make decisions upon because they are not undisplaced and they are not completely displaced, but it's easy to make decisions. So Eric, are there a couple of things? One is that MRI used at your institution for lateral condyle fractures, and then is there anything on the X-ray that would tell you this is hinged or not hinged, like the widening at the metaphysis compared to the articular surface, or the displacement at the joint line? What's your approach?
Yeah, thanks. We don't use MRI with any consistency. And in fact, I can't remember the last time I saw an MRI for a lateral condyle fracture at our institution. But we do use CT scan occasionally. We particularly have an in-clinic cone beam CT scan, so it makes it a little bit easier to kind of grab that image. But we also use a lot of ultrasound to kind of help make that assessment. But I would say for this one, particularly on that song internal rotation oblique, the way that it's displaced equally, when you look at it out laterally versus towards the center portion of that fracture, that to me suggests that it doesn't have a hinge and that it has that translation. So it's, and I think it kind of gets into the difference in how these fractures occur, whether it's a kind of a valgus maneuver or a varus maneuver when they're falling on it, and it kind of creates that difference. And so this one would be more in that kind of valgus position. So it's kind of shoving the fracture out of position.
I think this is what Eric was mentioning.
Just one more point. What do you think is the advantage of a CT? Because you can't see the articular surface, and what information you have on the X-ray, is it going to give you any more information?
Yeah, so the advantage for us is the timing it takes to get a CT scan. So the ability for us to get a CT scan happens relatively quick. We can make that decision quickly versus an MRI is going to take probably at least a week unless we admit the patient, which is a really high cost to getting just an MRI image. And I think what I'm looking for is trying to see if there's a rotational component, something that's going to force my hand to do something additional in the operating room. But honestly, we don't usually go MRI or CT. It would be ultrasound, or we're making the decision based on the X-ray.
Thanks, Eric. So, if you can see on varus and valgus, so a lot of time delegates would ask questions. So there was a slight, this fracture did extend to intra-articular. And here you can see, this is the fracture line on MR. And that's why internal rotation view is important. And one more thing, what we realized on MR, which was done outside, this is the fracture line on a lateral view. So your pin has to be from posterior to anterior. In a supracondylar fracture, generally your pins are going to be anterior to posterior. So you have to be perpendicular to the fracture site. So just some learning from the MRI for this patient. And how do you reduce this? By applying a valgus force. You close that gap. And after applying the valgus force and closing the gap, then you will do an arthrogram. And as Rroger very well mentioned, that on table, you internally rotate, again, recreate that position so that you can see the fracture well. And your wire has to go perpendicular to that fracture line in an internal rotation view so that you can close that fracture gap and hold it well. So here we did two divergent wires, and this is how it's seen on AP lateral and internal oblique view. And then the patient was immobilized in a plaster. So I want to ask a question again to both Eric and Rroger. What screw or pins? If you are reducing and fixing, this is a 5-year-old child. You have a very small metaphysis. So are pins all right, or you would use screw in this patient?
Again, I already gave my answer that I used to use pins and now I use screws virtually exclusively.
I would say
What do you
that
do? What is your preference?
yeah, we still use a lot of pins. We just make sure that we have fairly good pin spread, almost where that lower pin is almost perpendicular to the long axis of the humerus. And I think you can get some pretty stout fixation with that.
How long do you keep these pins? Do these pins remain outside the skin or inside the skin?
Outside the skin and for 4 weeks.
Okay. So we remove these pins at around 6 weeks in this child, and then keep repeating X-rays. And at 10 weeks, this is the showing healing. So I'm going to skip some of these slides about undisplaced lateral condyle fracture and directly go on to Manoj for the next variety of lateral condyle fracture. We have around 10 minutes left of discussion. So Manoj, let's make most of it.
Yeah, so this is a, hi everyone, this is a 9-year-old child with lateral condyle fracture, and as you can see, the metaphyseal fragment is slightly bigger. So I think we have an audience poll after this.
Yeah. Poll number 6. Ashok, please release poll number 6. Let's see what the audience feels. They've been listening very well, and they feel that open reduction and fixation almost 66%, but closely followed by 25% who feel closed reduction and arthrogram and fixation should be done. So Rroger, what would you do? And Eric, what would you do for this
I think I sort of gave my pitch to do open reduction when you're unsure. This is one that I personally would give an attempt at, do an arthrogram and give an attempt at closed reduction, but have a low threshold to open. I think you really can't be faulted for opening this one right from the outset, though.
So this is
Eric, what would be your choice?
Yeah.
Same, I would move towards open reduction pretty quick.
Manoj, over to you. What did we do in this?
So I think I'm more inclined with Rroger's view on this, that I would try close reduction, and when I find that it is reasonably well aligned, so I would kind of do a provisional fixation, but definitely would want an arthrogram to see whether I've achieved a satisfactory joint congruity. I'd like the panel's view on what they think about the joint congruity that's been achieved in this close reduction. Would they consider that as acceptable?
Yeah, so there are two components to your reduction. One is getting that the bony fracture line closed down and reduced, and the other is checking the rotation. The one problem that you can't address with an arthrogram is the rotation. You can have a really good looking arthrogram and a malrotated fragment. So not only do you need to have an arthrogram that looks perfect if you're going to try one of these with closed reduction, but you have to have full range of motion of the elbow, like normal range of motion of the elbow. Go back to the analogy of the hinge being off by about 1 centimeter. The door will wobble a little bit, but it's not going to move all the way. Eric?
Yeah, and I mean, I think, on your arthrogram there, I mean, it looks very good, just to throw it out there.
So Manoj, I'm going to skip a couple of patients because these are all arthrogram reductions and have a similar message. And I'm going to go to Kapil's case. Kapil, this is a 4-year-old child and completely tilted. So this is checkups 3. And how do we manage this?
Yeah. So there's an audience poll which is going on. It's coming up. Yeah.
Poll number 9. Okay. So there is no dispute here. I think 100% people dispute it out. So Rroger, what approach? You said it's a lateral approach, and Kapil, what approach did you do for this patient?
So I used a posterolateral approach, which kind of opens the same interval. It opens the interval between the triceps and the brachioradialis, but you're approaching the fracture from the posterior side rather than from the anterior side. And it gives you a better kind of exposure to the fracture and the articular kind of step off. So any comments on that, Rroger and Eric?
Yeah, I would say that the biggest risk of an open approach overall is AVN of the capitellum, and that's going to be an increased risk if you go posteriorly. So the blood supply to the capitellum is coming in the back, and so even though you can see at least the bony part, the lateral part of the fracture line very well, you're at an increased risk of AVN from stripping posteriorly. And then you really can't see very far medially. And again, some of these fractures can go all the way into the middle of the trochlea. So it's not just the lateral condyle fracture. And you can end up, and then you can't see that because the olecranon's in the way from a posterior approach.
Yeah, I agree with Rroger on the extent of what you can see, because I've tried, because of the reports. I said let me just try, and I struggled looking at the medial extent of the fracture through the posterior approach. Those who do posterior approach say that if you just go posterior and if you're not going lateral, then you're not risking AVN. If the AVN is when you go both, when you're going lateral and then you go posterior, then that is when you really mess up with the blood supply. So the series on the posterior approach, by Henricus, as well as the one that you pointed out, have not reported AVN with those approaches. They have said that, as long as you maintain the lateral and the anterior approach intact, and you just go posteriorly, then you're going to be fine. But I don't know if you were able to look at it really well with that approach, the medial extent of it, because of the olecranon being in position. I tried to lift it, I tried to maneuver the elbow, I couldn't see it very well. So it is challenging. I think if you do it more, I think you might get good at it. But when I tried it, I found it challenging. And one other point is, if you look at Song's paper, even for completely displaced and rotated lateral condyle fractures like what you show, he did close reduction on most of them and did not do an arthrogram. Okay, in his paper there were no arthrograms, and and so what I always teach the resident, or when I'm in the OR, is there is no harm in trying 1 or 2 times to close reduce even a severely displaced. You'll be surprised, once in a while, just like any other place, more displacement means more soft tissue stripping, means more instability, but at the same time, more movement of the fracture. And you may be able to, get it reduced closed. I will just try it once or twice just to, try. Of course, we are going to go with open reduction if it doesn't work. But at least, in the literature, they were able to reduce a lot of these rotated and displaced fractures even without an arthrogram, which I would not agree. I would, if I do a close reduction, I would do an arthrogram.
Yeah, so just a word about rare complications of AVN. So you could report a series of 40 cases done with a posterior approach without a case of AVN, and the next one could have it, and then you've got a really bad problem. So rare complications are generally, I'm not comforted by small or even medium-sized series that report no complications when the complication that is rare is disastrous. So there has to be a really compelling reason to in my mind, to do something that's risky, even if it's a rare complication. And I just don't see a compelling reason to go posteriorly when you can see that medial fracture line so much better anteriorly.
I agree with that.
We go to the last case. So we'll take one neglected case, which we do see very commonly, people coming after 1 year, 2 years, sometimes after 10 years after a fracture. So Kapil, please present your case and let's see what we can do.
Quickly, this is a 12-year-old girl who came about 5 years from injury. You can see her elbow deformity. That's a range of motion, and that's what her hand looks like. So I think there's a quick opinion poll after this. So late presenting.
Number 13, yeah.
Can have cubitus valgus, ulnar neuropathy, instability, and all of the above. Okay, so
you can present with all.
So it's all of the above, and these are all problems with late presenting lateral condyle fractures. You look at the next slide, that's what the fracture looks like. So you have the Milch type 1s which go into non-union and the Milch type 2s which go. So this looks like a Milch type 2 fracture. It's a reasonably large size chunk. And so the options for management in this include osteotomy of lower end humerus, ulnar transposition, and fixation in C2. So Rroger, any comments on how you would tackle this problem here? What would be
I think you have to address each one of those issues independently. And so ask, to what degree is the cubitus valgus bothersome? To what degree are there any ulnar nerve symptoms? And what does the range of motion look like? So if the range of motion is pretty good, then fixation in situ is going to be easier than trying to restore any sort of articular alignment. Those puzzle pieces don't fit together anymore. They're different shapes now than they used to be. If there are ulnar nerve symptoms, then an ulnar nerve transposition. And if there's if the cubitus valgus is a big problem, then an osteotomy either concurrently or secondarily is fine too.
Okay, so we combined all the procedures in this because the girl was a little symptomatic. In situ fixation, dome osteotomy, that's her 5 months later. And that's her 8 months later. So still a little restriction of flexion, but otherwise cosmetically improved and her ulnar nerve function improved as well.
We end this session with a quick review of a 35-year-old lady who presented to a pediatric orthopedic surgeon.
Kapil Taral, I just one question. What is the indication for the osteotomy? Like how many degrees of valgus is not acceptable? Or would you do it for every non-union?
More than 20 is our cutoff.
More than 20.
Yeah.
Okay, all right, thanks.
That does have stress on the medial side. They complain of pain on the medial side. So this lady had two problems: ulnar nerve palsy.
Mm-hmm.
Which came very late, almost 20-25 years after the injury, osteotomy. But if you can see, when we try to fix the fragment, as soon as I fixed the fragment, there was no mobility at the elbow. So here we had to change the strategy. I did only the osteotomy. We left the fragment as it is. We did the ulnar nerve transposition, and so it's important to realize that the elbow movement actually may be occurring at non-union in very long-standing non-union of lateral condyle. And in those cases, you should not fix, and at least on table test check by passing a wire whether how much the non-union is contributing to the range of movement of elbow joint. So with this case, I want to stop the cases here. It's 7:43, and we go on to the next session, and I want to invite Eric to share his slides and go on with his presentation on other elbow injuries, which includes radial neck fractures, the medial epicondyle fracture, and the miscellaneous injuries of the elbow injury.
All right, I hope you can see my screen at this point.
Yes.
Absolutely well, yeah.
Okay, good, perfect. Okay, so we're going to kind of catch everything else about an elbow kind of in this talk and kind of work our way through around that kind of area. I have no disclosures really at all. No book that I wrote on philosophy or anything. And we'll start out by talking about radial neck fractures and kind of remembering that when kids come in and have this idea that somebody kind of pulled on their elbow, maybe it was another sibling, maybe it was somewhat unwitnessed by another child, that they're not always fractures. Sometimes they could be a septic elbow. Sometimes it could even be a septic wrist. It's not even a problem with the elbow itself. But then there can be a variety of different fractures that can come out of this. So kind of keeping our eyes open for all those different potentials is important as we're treating these kids. When we do find kind of the radial head neck type fracture, we'll talk about just first a little bit the conservative management of those. There's obviously some discussion in terms of what's an acceptable position. Most of the literature talks about, the 30 degrees of angulation, but some of the arguments that we would make, at least here in San Diego, is that it perhaps is more of a translation type issue. Because if you're not getting the radiocapitellar joint realigned in a translational standpoint, then you're actually disrupting that proximal radioulnar joint and almost creating kind of a CAM injury that has potential complications on the stress changes to that articular surface. So when you're looking at doing these reduction maneuvers, it's really important to kind of make a full assessment of the position when you're all done, which is sometimes difficult. In these line drawings, you see this big osseous portion of bone for that radial head and neck, where a lot of the children you're treating, they're actually going to have only a tiny bit of bone, predominantly cartilage, and so it's really kind of paying attention to some of that alignment. I'll just give you an anecdotal one where we had a kid re-present over a year out. They were initially treated at our facility, and as it turned out, during the closed reduction maneuver, the head, which otherwise was completely displaced from the joint, when it got reduced, it was reduced 180 degrees from where it was supposed to be, so that the articular cartilage of the radial head was actually abutting against that, we'll call it the metaphyseal region of the radius, and the fractured portion of the neck was articulating with the capitellum. But with those initial films that they had with just a little sliver of bone, it went unrecognized until she came back continuing to complain of pain, and actually somehow managed to get treated surgically a year out and did relatively well, but I'm not going to show any of her images. So I guess that's the advantage of being young sometimes. But when we look at these reduction maneuvers, there's a bunch of different techniques that kind of go into how one can do this. The predominant method is placing a thumb over the fragment itself, and then applying a kind of lateralizing pressure to that proximal form, almost creating a Valgut or a Barris type maneuver, and getting that piece to pop into position. The only issues that have been really noted from a conservative management standpoint has been, myositis ossificans and potentially some limitations in motion. But I would potentially argue that that limitation in motion probably stems from incomplete reduction of the fragment. So the next level in treatment for these is going to be more of your kind of closed reduction percutaneous pinning. It's pretty uncommon that we would consider doing any type of in situ fixation. If we're going to the operating room, it's to get a better reduction. Sometimes you're lucky you can do kind of a closed reduction maneuver where maybe it failed in the emergency department because of the type of anesthesia that was being used. So you get to the operating room and you get better anesthesia, you're able to get it closed reduced, and then you're pinning it in that reduced position. Sometimes it requires a bit more in terms of how you're going to attain that reduction. We'll talk about those. One of the things I just want to point out with the imaging here is that we do not do any trans capitellum pinning. And I think that's been shown to have the complication of pin breakage and then being stuck, trying to find a way to get those pin ends out from the different bones that they're stuck in. So one of the first techniques we'll talk about is just kind of this basic joystick technique. This is one that I employ a fair amount, where it's a fairly small little stab incision, and then using the blunt end of a Kirschner wire or even a Freer or a Joker type device to just try to hold that fragment into position, as then I'm otherwise using that kind of Columbus technique to get that reduction. And this can be quite successful, quite easy. One of my partners who does a lot more of our kind of like congenital hand deformity work came up with this kind of indirect technique, because he believes that the issue is not so much that the radial head itself is out of position as much as the radial shaft is not in the appropriate position. And so he'll use this technique where he levers by pushing off of the ulna and bringing that shaft over laterally, and while maintaining the position of that radial head to achieve the reduction. And he's had good success with this, even in these kind of really significantly displaced radial head neck fractures. And once again, just doing a pinning technique for those. Then there's obviously the metazo technique. This one is what I consider a bit more futzy comparatively, but it is something that does achieve appropriate reductions. This is one of our former fellows in Texas that just kind of sent me these films that showed me that he could get it to work. But you're basically approaching the radius from distal at the wrist, and then passing in your kind of curved tipped either elastic nail or K-wire, depending on the size of the patient. And then you're going to spin the fragment into position and after you've captured it with that pin. And of course, by spinning into position, you already have the fragment captured. So it requires no further fixation other than what you already achieved here. You can see he used an arthrogram just to kind of confirm and help visualize the cartilage aspects of that radial head and neck, which I do think can be beneficial in terms of truly recognizing a reduction of that radiocapitellar joint. And I think one of the issues that you've seen here is none of these have shown any type of what we would officially call kind of an open reduction. We're usually reserving that for when all these cases fail, believing that open reduction in of itself can increase the risk of loss of motion and arthrofibrosis around that radius. So you lose kind of the supination and pronation function. So we're trying to reserve true open reduction techniques for when it's absolutely necessary. And then just to kind of hit on, because part of the talk revolved around doing kind of some grafts and osteochondral injuries. These can be actually quite devastating. This is just kind of looking at more of what I would call an osteochondritis dissecans type injury to the capitellum. But you can see contre-coup type injuries on the radial head as well. There's not great evidence supporting the use of resurfacing of the radial heads. Part of the issue is that most of the grafts and the shapes are coming from a convex donor site. There's not many that you're getting from a concave donor site. So the matching for the radial head isn't so great. And we've been in some discussions with some of our graft suppliers, so not using an autograft, but an allograft instead, trying to obtain radial head plugs, but that requires a market, and this is not a big market. So if you have a radial head issue, you're a little bit out of luck, and there's not a lot of good donor sites around the body unless the piece is small. In which case you have to decide if that's really causing a lot of issue, because a lot of times when it comes to joint resurfacing, the smaller the size, probably the less important it is in the overall outcome of that patient. But definitely these kind of osteochondral plugs have shown to be quite successful in terms of restoring both the contour to the joint and restoring function. One of the issues with not using an autograft and choosing an allograft is that there's been some reports, which I'm not sure have been truly published yet, but I just know from folks around town and around the country that sometimes you can get delamination of the cartilage and the bone interface when it comes to the allograft. But something just to kind of be aware of as you're treating these patients. So we'll talk about medial epicondyles, which is near and dear to my heart. And this is one of my favorite slides to ask which one of these fractures do you think is most displaced, because this gets into my concern regarding the ability to get appropriate radiographs for this. And so the question really comes into, here's the CT scan of the one on the right, and you can see that one's quite displaced. It just happens to look non-displaced on that image. So I think it's important to consider what type of imaging you're getting for the medial epicondyle if and you want to understand how displaced it is. And we'll talk about why or why not knowing that information is helpful. So looking at the different projections, you can see the APs. We also use internal obliques for the medial epicondyle, and then your laterals, and then our axial view type, where we're trying to really assess the rotation. And you can see these show varying amounts of displacement for the same amount of displacement. when we studied this. You can see the axials did a really good job of actually measuring the true displacement, whereas people were very consistent in the displacement they can measure with an AP view. They were consistently incorrect in the amount of displacement that there was. And so I think what that really comes down to is that the kind of standard AP and lateral views are not going to be very helpful when it comes to a medial epicondyle. Here's an axial view, what it looks like kind of in an actual live patient. You can see, depending on how you measure it, you can get very distinct measurements that are potentially a millimeter to 1.5 millimeters different. Then the question comes into how much variability are you willing to tolerate? And this is kind of showing what that CT scan of that same patient showed. So you can see potentially better areas of measurement is probably coming from that more dorsal side, just like you're doing the AP measurements as shown from the CHOP study in terms of the reliability of measurements. But in the end, I would suggest not using your AP radiographs to understand true displacement. You can do axial views or advanced imaging ultrasound we've done to determine how displaced fractures are. But I guess really the question is who cares what the displacement is? And so let's talk about reasons not to operate. Well, there's no evidence in the literature to suggest that it improves strength, no evidence of instability issues long-term. Even though we know non-unions occur, we don't have a lot of people coming in because they have symptomatic non-unions and really no loss of motion. So why do surgery on anybody? And here's some ideas like reasons to treat in the cast. You get infections and you might have to go back and remove those implants. I tell patients, 10 to 20% of the time, we might have to go in and take the screw out if we do surgery on it. Here's some just representative examples where they kind of look a little bit like some non-unionish kind of things, but these kids are fully back to playing all the sports they want to play, not having any issues. And technically there is some union that's happening. It's just that the bone looks kind of like it's funny when you look at the x-rays. So here's some reasons why we would operate. Obviously, if you have an incarcerated fragment, that's a reason. If it's an open fracture, you want to wash it out. And then there's been these reported indications in the literature over time where if the elbow is completely unstable, probably worth fixing ulnar nerve entrapment. And then this whole idea of significant displacement, depending on which author you read, that could be anywhere from really 2 millimeters to 2 centimeters of what significance is. And actually, if you poll a lot of people in the US, they will suggest that they always operate on it. They know that there's a fracture, they want to fix it kind of idea. And so the displacement question starts to get questioned itself. And so you can fix these with K-wires in really young kids. You can do cannulated screws, which is usually my preference because it's the easiest thing. But then we also use suture anchors, particularly for the fragmented type cases. And so we did look at kind of the question of this instability. Can you have problems, long term? Maybe there's some strength deficits. Well, depending on how much displacement you have, you can see at about 10 millimeters displacement, you really start to see some changes overall in terms of grip strength. It's not significant from the standpoint of having a 1% to 2% moment loss for every millimeter displacement, particularly if kids are adaptable and they can improve over time. But just understanding that there is some element of loss of function that maybe is not noticeable to the children long term. And then both the folks in Memphis and here in San Diego looked at where is the ulnar collateral ligament attached, and it for sure is attached on that medial epicondyle fragment. So there is still the question of instability that you want to pay attention to. We looked at kind of the outcomes of, some displaced ones, looking at dynamometer testing, really found no issues regarding strength, and obviously had this kind of sense of non-union relatively when we did non-op. But again, if there's no deficit in strength, does the non-union even matter? CHOP study looked at treating in cast versus not, and really no difference in the outcomes at 2 years' time. So really it begs the question, do the kids need to be fixed? So here's a kid, fell on her arm, 12-year-olds, obviously associated with a dislocation. My suggestion would be fixing that only because it has that associated dislocation. And that helps just restore your anatomy in a nice, easy way where you don't have to worry about the ligaments being a problem long-term. Same kids, but no dislocation. And actually the elbow doesn't look quite as bad because it's not dislocated at presentation. And these were his films. And so this one, maybe, you know, it's just that middle epicondyle doesn't look horribly displaced. This one just happened to get a CT scan for whatever reason, and it turns out to actually be a medial condyle fracture. So just kind of been talking about that, being aware that occasionally a medial condyle will masquerade as a medial epicondyle. That's in the literature, written up a few case reports of that. And then also understanding, well, how do you treat the medial condyle fracture? As a technicality, it appears that you could treat them just the same as you treat lateral condyle fractures, although we tend to put more screws like Dr. Cornwall does for his lateral condyles than we do pins. And when we've looked back, and we have some unpublished results looking at the complications of medial condyles relative to lateral condyles and relative to medial epicondyles. And it turns out that the complication rates are about the same. They're kind of hovering around a 15% complication rate, which really for the medial epicondyles and the lateral condyles included everything from non-unions, infections, physeal closures, heterotopic ossification, obviously ulnar-collateral ligament injuries for the medial epicondyle, as well as malunions. But for the medial condyles, it actually was predominantly just non-unions and then some transient ulnar nerve palsies, which usually resolved over time. And so there are complication rates associated with it, but they don't seem to be extraordinarily high as suggested by some of the early literature. They seem to be very comparable to the other condyle injuries within the elbow. So now moving down to the last thing, the olecranon fractures. This has like a huge array of how these present over time. And I think it's actually important to kind of pay attention to overall alignment, the age. Actually, I think one of the lateral condyle cases that I saw presented in the film that was kind of 10 weeks out, I noticed there was healing along the periosteum of the olecranon. So there was an associated olecranon fracture with that lateral condyle fracture, which appeared to go on to heal great without much treatment other than the cast that it was put in initially. But they're easy to miss, particularly in the younger kids. I think, you know, the gold standard statement to make with this is that I don't think you can go wrong with your tension band and pinning kind of technique. We'll talk about the difference between using a wire or some type of non-absorbable suture, but for sure this is the easy go-to that, you know, doesn't fail very often. So younger patients, you'll see a lot of these kind of injuries that involve the growth plate in that olecranon. So making sure that you're restoring that. And then the very young patient that can have that injury through the physis. So this one is a fractured olecranon, but it is through that growth plate and very difficult to see, but definitely warrants some treatment. And maybe it's just casting, but it's identifying that that's the area that hurts and that's the area that requires treatment. So otherwise you get suture versus wire in these things. You can see a lot of mine utilize suture versus the wire, only because I feel like I just don't like looking at broken wires in the future. And as long as everything healed up, then I'm okay with that. There's only one outcome study that was done comparing the two, and that was out of Atlanta. And they found that really the outcomes were very similar, except for the bigger kids. It was definitely safer to use a wire than to use suture. And so that's important to kind of pay attention to, is how big is the person that you're treating. So then you get into the older patients, and I believe in the adult literature, they're showing less use of these tension bands and moving more towards plating. I'm not adverse to that, although for a lot of my kids, we end up definitely having to take that implant out. And it works really well, and I've been very happy with it. And it's not that you don't have to take those pins and wires out either. But this is definitely kind of a bigger approach to get the fixation that you need. Just because the plates are made for bigger elbows, you can use some smaller plates and kind of come down to size. And I think over the years here, I think the technology's come along where the plates are getting better and better. So I'm not adverse to those at all. And then for some of the kids, I see a lot of kind of these more stress fractures related to the overhead sports, and been pretty happy with just doing screws. And as you can see, they don't have to be bicortical as long as you have kind of good fixation. And I think it's mostly by having the surgery, it might slow them down just long enough to allow their kind of stress fracture to unite finally. And I'm okay with that. And then just kind of want to touch on this one where with these olecranon fractures is just kind of paying attention to what's that ultimate position. Sometimes getting just a elbow view with your x-ray is not good enough. And I know that there's going to be some talks about Montesia's, so I won't belabor this, but recognizing that the subtlety of this can cause problems in the long term, and you really want to pay attention to what the overall alignment of that arm is. And I think that covers it for the trifecta.
Thanks, Eric. It was a long topic, covered very well. Sheetal, any questions for Eric?
Yeah, so I think a great talk, Eric, covered all the basics. My question was, what do you think about the pediatric terrible triad? Like, you have a radial head fracture, you had a dislocation, and you see a small flake of, a coronoid fracture. How do you approach, but the reason I'm asking is because the ones that I have treated operatively, they have actually not done as well. Like, they have a lot of stiffness. And the ones that I've kind of, carefully neglected or at least, treated them conservative, it seems like they have better, we don't see them that often, so I don't have like a lot of experience. I'm just letting you know that, the adult world teaches us that you fix them, but what is your take on a pediatric terrible triad? And maybe, Rroger can also comment.
Yeah, no, I think that's absolutely the true statement is kind of that benign neglect in some respects. I feel like does really well in that population. Now, obviously making sure like the radial neck is in the right spot and kind of making sure you have good alignment, but for the kind of the subtleties that represent more of the capsular injuries and the ligament injuries, not kind of doing my best to ignore those. I've been very happy with, and over the last decade and a half, I think I've only had to go back and do surgery maybe on one kid to restore some of the collateral ligaments, and because you don't always know the full extent of that injury. But I think for most of kids, they do really well in a cast.
Yeah, I would agree. I also want to underscore something that you said earlier, Eric, about the translation of the radial neck fractures, especially the medial translation of the distal fragments. You have medial translation of the shaft. So if you have a terrible triad type injury, or even just a radial neck and an elbow dislocation, you have periosteal stripping on the anterior coronoid. And so that periosteum is all lifted up. And then the distal part of your radial neck, so the radial shaft, is then tucked medially under all of that periosteum. And if you don't get that out and the radial head reduced to satisfy that end, you can get a cross union between the radius and the ulna, even with non-operative treatment. So you don't expose it at all, but end up with a cross union. And that's really a big, big problem. So I think in situations where there is a really a good clinical suspicion of a bad injury, bad soft tissue injury around the elbow, then paying really close attention to the position of your radial neck can be important.
Okay, so can we go with cases, Sheetal?
Yeah.
There was an audience question.
Please.
Is your tolerance lower to fix the medial epicondyle if there is a fracture dislocation of the elbow?
Yeah, for me, absolutely having the dislocation, I will move towards doing surgery.
Thank you.
So apart from this talks, there are a lot of recorded talks by our Indian faculty which are in IFICS treasury, and I would request all the audience to go through them. That's the work for the week. The weekend we are having these sessions, but Monday to Friday there is a lot of work for you to do by looking at those talks. So let's go through some of the cases of other elbow injuries. So, Indian movies, again, we have a movie called Pati, Patni or Wo. So we have supracondylar, lateral condyle, and these are the other elbow injuries which are equally important. And over to Manoj Padman to discuss the first case of radial neck fracture. Manoj, over to you.
Yeah, so this was a 4.5-year-old child. These were the original trauma films. The treating surgeon thought that this was innocuous injuries and treated it in plaster. I think there is an audience poll as to what would be done. Is it?
So Manoj, yeah, those are the results from you.
Yeah. So as fresh injuries, I think, I don't know what Rroger and Eric would say about that. As fresh injuries, I think they would agree that this would need to be reduced and fixed, even at 4.5-year-old. Is that something which they would accept?
I mean, I definitely wouldn't accept where it's at, but it potentially could just be close reduced without fixation.
Agree.
Yeah. So this presented almost 10 days later. If you could move on to the next slide, Lateral. So these are when they presented about 2 weeks later. So delayed presentations. Do you have a cutoff? Again, question to our panel here. Do you have a cutoff as to how long would you kind of wait before doing a reduction or be accepted? Is there a cutoff?
So I don't have a hard cutoff. I don't know about Rroger, but at some point, I suppose you're just getting into doing an osteotomy to put it back into place, and
So because they presented late, Rroger, do you have any view on this? Late presenting radial neck fractures? Do you accept them? Do you always try to correct them?
Well, I think you have to take those one at a time. And if, again, there's the capability for remodeling, they're young, there's not terrible articular malalignment. So there's always some degree of incongruence of the radiocapitellar joint with a displaced radial neck fracture, a badly displaced radial neck fracture. But if you don't have a bad cam effect and they've got decent motion, I would allow some remodeling to happen before just making a decision about an osteotomy. But my biggest concern with radial neck fractures is a non-union or avascular necrosis. So we certainly, as Eric mentioned, we get into that when we do open reductions acutely. And so if you do an open reduction at 3 weeks, I think you're even more asking for a vascular insult to the radial head itself. So I would drag my feet and then make a decision about an osteotomy based on motion and articular congruity later.
So one question I want to ask is, in literature, always there are angles about acceptability criteria. So in a younger child, 45 degrees of angulation will remodel. In an older child, more than 10 years, 15 degrees will remodel. So how do you measure these angles? What position, what X-rays, and how do you really measure? And if it's 14 versus 16, or 44 versus 46, does it really make a difference? How do you take your decisions in those cases? So first to Eric and then to Rroger.
Yeah, thanks. I'm not a big fan of measuring the angles because I think to the point that you're driving at is depending on the position of the forearm when you're getting that X-ray, you can change that angle and make it look better, make it look worse. And I suppose you can sit down with fluoro and determine what the worst angle is and make the measurement and then make your decision. But I guess for me, I really go more on what I would call a gestalt, where when I look at it, if it looks like the radiocapitellar joint can remodel and accept that position, then that's what I go for. And obviously it varies based on the age, but to trainees and everyone, I'm not very forgiving of them giving me numbers.
Yeah, so Manoj, you want to talk about what happened?
Yeah, so this child was only 4.5-year-old. at 2 weeks, I chose to get the plaster out and get it moving. And fortunately, it went on to remodel both clinically and radiologically. So that's about a year down the line, complete radiological remodeling. And so I think that's alluded to what Rroger said about.
Rroger, what is your take on the angle thing? Like, do you have angles that you go by, or like Eric said, that you would look at the X-ray and the radiocapitular alignment and see if it will be remodeled? Do you also make decisions based on motion, like pronation, supination?
Yeah, I agree completely with Eric. I think it's very difficult to get reliable angles, and you'd have to take them through fluoro to get the maximum, the angle of maximum angulation. And even if you could precisely measure the angles, the literature is all over the place as to what's acceptable, and it varies based on what you're trying to decide. Anything more than 30 degrees is worth a closed reduction attempt, but if you make a decision about an open reduction attempt, you'll accept up to 60 degrees because of the risk of open reduction. The numbers are all over the place. They're unreliable. I again, hate to say it, I go with Gestalt, just like Eric said. Articular alignment, motion, and where that shaft is. I think translation is an underappreciated component of this displacement.
So let's see, this is Premal's case, and here they say the angle is 45 degrees. 12-year-old child, older child. And let's ask the audience, Eric, what would you do? So this is an X-ray which shows maximum displacement. 12-year-old child, closed reduction or K-wire assisted reduction? What's your choice?
Yeah, so I'm also a big fan of having the trainees, when they're still in the emergency department with this child, to at least give it a go and see if they can get it back into place. I've been really impressed by the ability for them to achieve a closed reduction. And for us, saving the cost of going to the operating room and all is well worth the attempt in the ER.
So I want to ask Dr. Wilkins, he taught us about different methods, reduction in extension, reduction in flexion, reduction in supination, pronation. So how should we reduce this fracture, a closed reduction?
Yeah, I'm a big fan of the Kaufman technique, which is actually a flexion at about 90 degrees and then forced pronation. And I've found it really makes a lot of difference. And I've had pretty good success with that in severely displaced fractures. So I think that's a technique that I prefer. The problem with the so-called Patterson technique, where you have to push against it, usually a lot of swelling, and it's a little bit hard to, it's hard to put your finger right over it. And I've done the percutaneous, and that works right. One of the things that I think that they don't emphasize when you do the metazo technique, you really need to sharpen. It's a little tough to get up there, but if you have the blunt point, you can't get into the radial head because you can't cross the physis. So the best way is to go ahead and make it sharp so that you can get into the epiphysis and get past the physis so that you can have, rotate a little bit better. So those are the things that I would suggest. One of the other things that I would suggest also is that when you talk about the Jacob type of lateral condyle fractures, and even the Jacob 1 or 2, you need to look past the bones. And you presented that one of those first cases that had a lot of lateral swelling. And I go more on that. If they've got lateral swelling, they have a lot more severe injury. And so those are the ones I'd be more ready to go ahead and do some kind of sensation of it, because if they have a lot of lateral swelling, then they probably have a lot more soft tissue thing. And one other thing about medial epicondyle fractures is that you really need to start early motion, because it's usually and often associated with elbow dislocations. And with the elbow dislocations, you have a lot of soft tissue injury. And so I think the thing with medial epicondyle fractures is you really need to start early motion.
Thank you, Dr. Wilkins.
So those
So
are-
this was, after a close reduction. So one must try a close reduction. There are various methods. Our colleague Dr. Maulin Shah also has published a method recently. So you can do it in different positions, and most of the time you end up using combination of the methods, whatever works, to have a close reduction. So Eric, would you accept, this close reduction, and would you fix this or just immobilize in a plaster at this stage if it was stable?
Yeah, so I'm happy with this reduction overall based on where that started. And if I was in the operating room, I would usually put a pin in because I would hate to lose that reduction because I didn't pin it.
Okay. So this is how it was treated. Chasnal, can you come up and show this case? 10-year-old child with elbow injury.
This was
Eric, I'm sorry, Eric. When you pin it, do you go from the proximal to distal, and you worried about the nerve? Like, how do you prevent a PIN injury when you're pinning the radial neck?
Yeah, so I do go proximal to distal, and usually I have the elbow in the position I'm planning to cast it in. So I'm not going to be changing any of the positioning. And then I think if you keep it down low, you're going to stay well away from the PIN, and then you obviously don't want to send it through very far on the distal side.
Rroger, would that be your choice as well? Like fixation, if you get a good reduction like what we had on the previous case, how would you fix it, or would you fix it at all?
I think it depends a little bit on the stability. So if you get the radiocapitellar joint congruent, then you've got a really inherently stable fracture. It's sandwiched between the distal fragment and the capitellum, and it's locked onto the capitellum. So I don't often end up fixing these if you get a really good close reduction.
Right. So if it's stable, you need to reduce, and if the reduction is acceptable and stable, you need not fix always. So Chasnal, what happened with this patient?
So this is a 10-year-old girl, and she had this acute injury, and the radial neck fracture here, it's almost displaced, which as per classification, it's more than 80 degrees here, or type 3 O'Brien. So a quick poll for the audience. How would you
Poll number 17. Poll number 17.
Yeah.
I'm going to put back the X-ray.
So it's,
Please launch the poll. Can you see, Chasnal, the results?
Yeah. So the results are, so we have maximum 75% who say that we can close reduce this and fix it. And there's a 14% who would like to open. And there are few who probably 10% just want to close reduce and give a plaster. Yeah, so
Eric, would you ever open this? And what are the problems with opening a radial neck fracture?
So I wouldn't move to opening it without trying the close reduction first, or trying kind of those percutaneous reductions first. But my indication would be not being able to get it back where it's supposed to be, and then I move towards open reduction with the presumption that something is blocking that reduction, which could be the annular ligament, depending on the location of where that fracture is.
Okay. So, yeah, so like I said, this was more than 80 degrees. So I went for a reduction with the intrafocal pinning, and earlier discussed by Eric, with a small stab incision, a wire is inserted. And this is just to maneuver the radial neck with the shaft. And so the entry point is slightly more proximal and near, so that we can bend and not cause an dent on the skin. And this is a temporary wire. And once the reduction is achieved here, this can be pulled back, and another wire, depending on how the movement is on table or how stable it is, can be done. So in this case, I added another wire without fixing the fracture, but just an intrafocal pinning, which was holding the radial neck there and crossed across the shaft towards the coronoid of the ulna. Next slide. So, and this were the post-op X-rays and the follow-up of the child. Yeah, so this is the illustration for the technique again. And I think this is a very easy and a quick technique, and even with so much of displaced fracture where the neck is actually parallel to the shaft, it can be reduced with this maneuver. And this is the child at follow-up of around 1 year. That's it. So,
Eric, when we read different books, there are different methods. Some people go intrafocal, some people push the head. So what's your choice? How do you manipulate with the K-wire? And do you use a blunt one or a sharp one?
I usually use a blunt one just so that I don't get hung up on not being able to move it. I think that either way works if you're just going to try to directly push or try to lever it. I tend to try to lever because then I feel like you can really get that you're achieving the goal of both bringing the radial shaft lateral as well as the keeping that head center or medial. Versus pushing, you may not be achieving that goal of bringing the shaft out.
Yeah, and if I may just highlight one finer point about the lever technique, where if you go through the skin and all the muscle from distal to proximal, then you're fighting against all of that skin and muscle as you try to lever it proximally. Whereas if you go antegrade through the skin and muscle to the fracture site and then pull all of that skin and muscle back down while you're trying to get into the fracture site, then all of that soft tissue is helping you achieve the reduction. It's not hurting you. So otherwise you're levering around the skin, not levering around the fracture site, and you're actually moving the fracture in the wrong direction. So I think that's just a finer point that can make it much easier.
That's a good point.
So any of
you would feel the need for an arthrogram here to look at the radiocapital alignment, or you just look at the radial epiphysis and you're pretty happy about it?
Yeah, I rarely do an arthrogram.
Yeah, I would only do an arthrogram if it's a completely unossified radial head with just a tiny fleck of metaphysis.
Manoj, your case.
Lateral, can we have one question? Two people have asked.
Please.
What should be the position in which we will introduce the wire to percutaneously reduce radial neck to avoid PI and injury? Where will you enter the wire?
So pronate the forearm and come in more posteriorly than direct laterally. That can help.
Yep.
Okay. So Manoj, your case here. Manoj, is he here? So anyway, so this is a 7-year-old child with radial neck fracture, and this is how it was reduced and fixed. And now child has come to you 9 days post-injury. So Manoj, take over now.
Yeah. So this is fixed elsewhere with these wires, clearly not in an acceptable position. So presented at day 9 with this position. So what are your options? I think there is an audience poll on this.
Yeah, so let's open the poll. So remove the wire and accept current position, or continue with the wire, redo close reduction and fixation, or primary open reduction. So these are the options. And that's what the audience says. Manoj.
Yeah. So again, I'd like the panel's view on this. Day 9, what are the chances of getting it with simple close reduction? Would Rroger or Eric consider open reduction if you can't achieve a satisfactory reduction, or would it be based on intraoperative findings in terms of mobility? Can we?
Yeah, I think that's just it. Is if you can pull that pin and actually achieve a reduction, then you don't need to go open. And it's the reduction plus the mobility, as you're assessing that. But
so
yeah, I agree.
What did you do? Yeah.
So this was, the wire was taken out, and if you could just move the slide, we found that it was mobile. So you use the K-wire lever technique to kind of push it back into place and stabilize with a metazole wire. An arthrogram was done to confirm that it didn't go into the joint, and intraoperatively there was full range of movement.
That look good.
So learning points here are that, if you have a radial neck fracture which presents late, and which does happen very commonly in India, in Bangladesh, in Pakistan, in Nepal, it's going to happen that children are going to come late to you. And sort of a late presentation supracondylar, after 10 days we were told that don't touch, but late presenting radial neck fracture, there is always some mobility. And it is possible to use a leverage technique and get a close reduction and then stabilize it with a intramedullary wire or a intrafocal pinning. So what we have learned is that up to 45 degrees can remodel, 30 degrees in older children can remodel, but these angles are just figures and one needs to look at the overall picture. And the aim of a technique is to get the alignment to acceptable limit. You may not be able to get 100% alignment in all the patients. So this is an 8-year-old child with elbow injury, and this is how it presented. Okay, so you can see that this little funny fracture where you have shaft here and the radial head is here and the capitulum is in between. And let's run the audience poll and check what the audience wants to do in this patient. Can we run the audience poll?
Can you go back to the x-rays?
Yeah.
And get rid of the...
So close reduction and fixation, that's what...
I'd be a little concerned about posterior translocation, the posterior instability. And sometimes with radial head fractures, especially in kids, you can actually tear the lateral collateral ligaments and they'll displace posterior and lateral. And I'd be a little concerned on this one that it's a little bit posterior. So I would, and that one probably need to be stressed. That one probably occurred during the distal reduction. But I'd be a little concerned that you may have some associated lateral collateral ligament instability. And you may need to put him to sleep and test the stability of this because it's a little bit posterior. And that
this child had a history that there was an elbow dislocation and they had gone to a bone setter. And, this is what happened after this. So Eric, what is special now? Dr. Wilkins suggested that there was an instability and it's a different fracture. What would be special about this fracture as compared to other radial neck fracture which we have seen?
Yeah, I mean, this is essentially kind of a Montesia type variety. And so you have to consider it in that way.
And how would you treat this? How would you treat this fracture?
I mean, I think part of it is going to be, I will probably more readily go to open on this particular one versus trying to push it around percutaneously.
So, Taral, this is one of those, relocation injuries rather than dislocation injuries that, when the elbow reduces, that is when the radial head gets trapped behind the distal humerus. And, even though there have been techniques described in the literature, the paper you quoted was the technique for percutaneous reduction using a K-wire. I think, it would be worth opening it, after one attempt because it's very difficult to reduce this closed.
It's really not possible to reduce this close. We did an open reduction and secured the radial head because after reduction, it was still unstable. And the important thing is when you are doing an open reduction here to maintain the hinge, you will always find a hinge over which the radial head can be toppled back. And it's very important to give a varus force to make space for the radial head to sit back when you are opening. So it should be a very gentle open reduction And this child, after 3 months, we removed the wire and he had good range of movement. So this is the Jeffries type 2 fracture of radial neck fracture, which Sheetal describes the relocation injury. The elbow is dislocated, and while reducing, the radial head gets fractured. And the capitulum gets trapped between the radial head and the radial shaft. And these are generally to be treated with an open procedure. Kapil, your case here, some more complicated radial neck fractures they are dealing with here.
Okay, so this is a 3-year-old girl. She came with this olecranon and radial neck. And I'd like to get Eric's comments on what do you think, Eric, is going on? Is this a kind of a Montagia variant, or is it olecranon fracture? Is this kind of a pattern that is common? What are your thoughts on that?
Yeah, I mean, I think this officially qualifies as a beta 4 Montagia fracture.
And how would you go about managing this? Would you try open reduction for the olecranon or closed management?
Actually, I think you can still attempt a closed reduction of the olecranon, but this kid's a little bit older, so I think you ultimately do some type of pin fixation like you did there.
So this is what we did. We did a closed reduction and pinning of the olecranon, just percutaneous pins. And then we did a levering of the radial neck and kind of an intrafocal K-wire. And I think that's how we got it. It went on to heal up reasonably, and the child got a good range of motion. So
would there be a risk of cross union here? Yeah. Yeah, Sheetal, you said.
There is another trick of reducing these fractures. If you go back to your pre-op X-rays, you see the widening of the olecranon. This is a known pattern of injury. We've seen it, a few times. When you approach the olecranon from the posterior aspect, and it's like the fracture site itself you would be able to see the radial neck fracture through the olecranon. And what you can do is, instead of maneuvering it too much, you can just use a very fine instrument, maybe a freer or a K-wire, and get the head back onto the radial neck through the olecranon split, which is already there. And then you just fix your olecranon like you would do. So you don't need a separate procedure to fix your radial neck. And it's very useful. The split, it's almost always in this plane. And your K-wire typically, would be oblique rather than coming, straight, proximal to distal, like in a transverse fracture. So you would be able to treat both injuries from one approach.
Yeah, and I think the other thing too, these olecranon fractures are a little different in that oblique setting. You tend just to be able to pin it. You don't have to use tension bands or anything.
Yeah, correct.
Right.
Exactly.
Right. So this is, Sheetal, you were talking about one of these injuries. It's a dislocation and radial neck fracture. So how do you manage? And let's ask the audience, how would they manage? So can we run this poll, number 22? So most people feel that close reduction of elbow and assisted reduction of the radial neck. So is that easy, Eric? How would you manage? It's a very severe injury. And what are the complications you can expect after whatever treatment? How would you manage this patient?
Actually, this kind of gets back to that question about like the kind of turbo triad type elbow injury, where I like the audience's response of trying to do kind of close reduction. Maybe you're going to pin that elbow or pin the radial neck. You're going to kind of minimize effort early on and try to treat those ligament injuries, the capsular injury with casting, and then probably some early mobilization if possible, just to kind of make sure they're not getting stiff. But that depends on the age of the patient. So the older they get, the earlier you have to start mobilizing. For a kid that with this kind of, looks like skeletal maturity, you can treat them casting for a while and they'll be fine with their mobilization later.
So, we could get close reduction, and but after 3 months, there was a cross union between the radius and the ulna, and though patient has reasonable range of movement and but the pronosupination is restricted, and this is a non-dominant hand, and the parents don't want it to be treated further. But with the severe injuries, stiffness of the elbow, whatever you do, does seem to be an issue. So Sheetal, is there any way, would we, if we do an open reduction, can you prevent it, or there is no guarantee, in such elbow injuries in children about range of movements?
The thing is that the most common complication of a complex elbow dislocation, which is a dislocation with a fracture, is loss of motion, is stiffness. I have seen instability to be an issue, but only in adolescent, not in kids, not in a child who is young. So I'm not really concerned about instability, but I'm more concerned about stiffness. I have had, as I had mentioned, before, that when I tried to treat the ligament as part of this injury, I ended up with significant more stiffness than I would have been otherwise. So my take on this is, reduce the dislocation, of course, treat the fracture like you did, but then start with early range of motion, because I'm more concerned about stiffness than I'm concerned about instability here. And as I said, I've not seen instability to be an issue in someone, less than 10. But I've seen stiffness to be a significant issue.
We'll go quickly through some, old presentations, and then we come on to more question and answer from the audience before we end this session. So Kapil, quickly, let's go through this.
Okay, so quickly, this was a 9.
Yeah, Rroger has a point.
Rroger, you want to say something?
Yeah, do you mind going back one slide? And this is exactly that situation that I was talking about, where you have a dislocation and a radial neck fracture, and you've got periosteal stripping on the on the coronoid. And if you look at the X-ray on the bottom left, there's still about at least 50% translation of the radial neck. And so your radial head is basically sitting directly touching the coronoid there. So that's the setting where you get a cross union from even closed treatment, even if you get a closed reduction. And so in this situation, I pay a lot more attention to the translation of the fracture of the radial neck than I do about angulation. And I really want to try to get that radial shaft as far away from the coronoid as possible so that you don't get a cross union.
But then how do you fix it? I know you can get it there, but how do you get it to stay there?
So if you use a metazo fixation, not for reduction, but for fixation, that can help. And that can even give you enough stability that you can move it a little bit sooner. So, because percutaneous K-wires can also work, but you obviously can't move those at all while they're still in.
I thought you were going to use screw.
No screw for this.
Yeah. So that's a 9-year-old girl. She's about 16 days from injury. Eric, any comments on how you would go about managing this? Would you try a closed or open or accepted?
No, so I would try to reduce it. The issue that I see even now is it looks pretty sclerotic, and I'd be worried that you're going to get AVN no matter what you do with this radial head.
Okay, so Taral, can you move the slide? Maybe see what, okay. So those are the other views, and I think on the side you can see there's already some callus which is forming, and so we had the same concerns that this fracture would not move, and they already came with a CT scan. So what we ended up doing was that we kind of poked a wire to soften the callus, and then we kind of joystick the fracture to move a little, and then hooked it with the metazo K-wire. And we were able to line it up reasonably. And that's about 2 weeks later, and the wire kind of went in a little too much. So we pulled it out and started ranging her elbow. And I think she ended up with a reasonably good result.
Yeah, Manoj, one more patient.
So this is another one, delayed presentation. This was injury on pictures on day 1. This was not picked up. It was just treated as a simple injury and treated in plaster. the patient presented 2 weeks later with this position. So what would be your take with regard to this question to Rroger and Eric on this?
I would say to Kapil, yeah, because he was able to manage the previous case.
Yeah.
So I'd probably attempt the same. So I counsel the family that we'll give it a try. If we can, we'll get it better. If not, then we'll probably accept it and see how it remodels over time. And that would be my take. I wouldn't go for an open reduction, definitely.
You will not go for an open reduction?
No.
Yeah. So having had some good results with younger children with conservative management, just getting them to mobilize, I chose to mobilize it. The child was lost for follow-up until he came back 6 months later with another injury. You can see the fat pad sign, and that I got an opportunity to kind of evaluate him clinically. So he came back with another injury because he's functionally doing well. So he did not come for follow-up. So this was when he came back 6 months later, kind of supervised neglect or unsupervised neglect in this case. So we took some x-rays just for our learning point, even though he had a good functional arc. So the x-rays at that time, Tarul, could you move the slide?
No, we don't have those x-rays.
Oh, okay.
Yeah.
So what are the implications of malalignment? The question to the panel again is, what are the implications of radial malalignment on x-rays, even though they have a functional arc? Are there any long-term studies about it in terms of problems later in life?
Not that there's any long-term study per se, but I guess it depends on where the radial head and neck end up, because if it doesn't really reconstitute that radiocapitellar joint, then I think you're at risk to have the radius, slides proximal relative to the ulna, and then potentially have, wrist complications down the road. Is probably the biggest thing. But if it happens to get in there and buttress it so you don't achieve that, then you could be okay.
Yeah, and radiocapitellar arthrosis is obviously a concern. And then if that becomes limiting and painful and you attempt to resect the radial head and you do it too young, then they can overgrow, like terminal stump overgrowth from a tibia amputation, or they can end up with proximal migration of the radius when you take out the radial head. And so then they end up with wrist problems, as Eric mentioned. So I think you're kind of stuck. And to continue the chess analogy, you've by accepting a 90-degree deformity there, your opponent has some real options there to hurt you badly, and then you don't have good options for those options. So I think whereas if you have an attempt at getting that back into place and you get it even just a little bit better with a percutaneous osteoclasis that was done very nicely in that other case, then I think your opponent's options are much more limited.
But you would not do an open reduction. But you would not do an open reduction, Rroger.
So again, there are different thresholds for whether or not to reduce it and whether or not to open reduce it. And if I couldn't get it to budge at all, then yes, I would open it, because if you leave it out like that, you're going to have problems. You have 100% rate of incongruent radiocapitellar joint and ultimate problems. Whereas even if you had a 30% risk of AVN from an open reduction at that point, I think you're still in better shape. So, that was just all the way off.
So would you preferentially go in for an open reduction at that stage, or wait until it's all healed up and do a corrective osteotomy?
I think, I don't know if there are good comparative studies, and it's a little bit apples and oranges, but I don't think you can say that there's a higher risk of AVN with an open reduction at 9 days versus an osteotomy, because osteotomy certainly has risks as well. If it were a lot safer to do an osteotomy later, I think it's worthwhile waiting, but I don't think that that's the case. And then again, you do have some remodeling of the puzzle pieces, and they won't fit back together again at the radiocapitellar joint. So I would still, at day 9, I would still try to get this lined up, even if you can get lined up better. So there's a better chance that the radius and the capitellum will stay lined up versus becoming unstable, as Eric mentioned before.
So one question I have is, if there is a painful radiocapitellar movement and if you have to excise the radial head, what is the lowest stage where we do it? Is it 12 years, 14 years, 16 years?
What is the earliest stage?
Yes, yes.
Yeah, that's a little bit tricky to pin down exactly, but I would say approaching skeletal maturity of the radial neck physis, and that's, you know, that's pretty vague, but it's probably around 12 or 13 or so, because obviously if the elbow is going to stop before the wrist and whatnot. But yeah, the trouble you run into when it's too early is that you just get terminal overgrowth, which you then have to re-excise.
So, Carol, we have a nice question. What is the role of indomethacin in preventing cross unions if you feel that patient is likely to have? Would you start indomethacin or not?
So, Rroger, you want to answer?
Yeah, there are no data on that whatsoever for these elbow injuries because they're so rare in this population. It might consider if for some reason you can't get it reduced, but I don't think there's any substitute for getting the bones further apart and getting them moving as soon as you can. So I don't know is the answer.
Yeah.
I could.
Edmonds, you want to share your opinion?
Yeah, I mean, I think that's the same. Motion is king.
So you, in your paper, you said that you would use joystick maneuver. So somebody, Dr. Mukhi has asked, when you pin post-operatively, if you find radial nerve injury, what do you do? Do you wait, observe, or do you open and redo it, the fixation in radial neck fractures?
Yeah, I usually leave the pin in place, and then I may pull it maybe a week early, but otherwise the injury to the nerve's been done and no harm in leaving it for a week or two.
More questions for you. Is it advisable to get a CT scan in every suspected medial epicondyle fracture to avoid missing on X-ray?
Yeah, no, that's a good question. The answer is no. I would definitely not do a CT scan on every medial epicondyle. There are other ways to assess it, as the axial view or ultrasound. Less radiation, I think, is important in the grand scheme of treating children. So,
somebody wants to know, what are your views on terrible triad? Do you want to open fix it or you want to conserve it? What are your views?
yeah, definitely. I tend not to open. Definitely try to treat those more closed to minimize what the soft tissue injury is going to be, and as we discussed.
And more for you again. What is your preference of treatment in cases of symptomatic non-unions of medial epicondyle?
Yeah, so for those, I usually will do open, kind of take down the non-union, the fibrous portion of it, and then oftentimes you're not going to get it back to its native bed, because usually by the time they're presenting, significant amount of time has gone by. I've tried to do like pie crusting and trying to get the fragment back into place, and what I've discovered is just getting fixation along the condyle will make the non-union portion go away. It'll reestablish stability, overall to the elbow, because all those fibers of the ligaments, everything's been shortened anyways. It just needs to have that stability. So even though you're kind of fixing it in a malunited place, by achieving that union, that seems to get good results.
Another option for that, if it's valgus instability, that's the reason for the symptoms of the non-union, is a collateral ligament reconstruction.
Yeah, for sure.
With a tendon graft, and you can leave the epicondyle there. You can take part of it out if you need to, but you can use your bone tunnels through the metaphysis, through the medial condyle instead.
So you don't treat the non-union, but you treat the instability instead.
If it's instability that's the problem, I'll treat the instability.
So another tough question, whoever wants to volunteer. In elbow traumatic fractures and operative reductions in pediatric populations in general, what are the precautions against having myositis ossificans?
Yeah, so Rroger, first, how do you prevent myositis ossificans?
So that as a problem overall is less of an issue in children than it is in adults. Obviously, head trauma is a risk factor. As you get into the teenage years, it's a risk factor. But it's generally not something that we live in fear of in pediatric elbow trauma in general. If there are some really substantial risk factors, a lot of blunt trauma to the muscle around there, such as the arm being run over by a vehicle, then that could potentially cause problems. But I think if you have a lot of soft tissue injury where you're worried about secondary complications such as that, then gaining enough stability to the fractures and the injuries that you can move them early is still the best approach.
I think if I can add here, probably Rroger and Eric don't see the kind of patients we see, because we have the native people, the native traditional bone setters who rub and massage the elbow in children. And we have a very high incidence of myositis in children because of native treatment. And then they come to the orthopedic surgeons. So I guess the advice people want is that if the fracture is late and has undergone native treatment by massage, it's best left alone because the complication has already occurred, rather than take the credit of adding to the insult by surgical intervention, and rather than treat the complication when things are more quiet with arthrolysis.
Sounds like a great idea. I would defer to the wealth of expertise on in India.
Yeah, we have something similar in Mexico with the sobradores, and they do that same massage.
One of the things that, one of the things I think you folks in India need to do, and I think you're thinking about it, is that you need to develop a booklet or some kind of monograph on what do you do with delayed treatments. Which one can you treat? Which one can you not treat? You see a lot more osteomyelitis than we do. And I think it's very valuable. And it'd be valuable because a number of us go to countries with limited resources, and we need to know really things that we don't see in the United States. So I think but I think that's something that you really ought to push on, because that would be a very valuable thing, because there are lots of countries that they don't have C-arms. Some of them don't even have x-rays. And so those are things that I think that would be very valuable to share your experience with it.
Right.
Very nice suggestion. I have one interesting question for Dr. Cornwall. Syed Imran is asking with regards to arthrogram, there is some literature suggesting toxicity of the contrast material to the chondrocytes. What are your thoughts?
So that I'm not aware of. I typically are not concerned about with a small dose of contrast. I typically dilute it 50% and then inject maybe half a cc of it. And there's usually enough. So if you're performing an arthrogram in a setting of a lateral condyle fracture or other intra-articular elbow trauma, there's usually enough injury to the capsule that it dissipates out of the joint actually very quickly. You only have about 15-20 minutes or so of visualization.
There's a question to Eric. When you have a medial epicondylar fracture, do you transpose the ulnar nerve? Do you need to do that?
Yeah, no, I rarely do a transposition of the ulnar nerve.
I had one question, Eric. On the lateral condyle, you said you take out the pins at 4 weeks. I just remember one of my complication of lateral condyle was pulling out the pins, and afterwards the fracture moved and went into a malunion. It flexed, that piece flexed, and the patient luckily has not required any further intervention, but it's been 4 years and I follow that patient. But in hindsight, I would probably not have, removed that pins early. So is there something that you do differently? Like once you take it out, do you put them back into a cast if it's not healed, or do you not take out the pins if there is no healing on X-ray? I mean, there is not enough healing on X-ray.
Yeah, no, I think you hit that on the nail. So I pull the pins at 4 weeks because the evidence of increasing rate of infection risk about that time. but then they invariably go back into a cast for an additional 2 weeks.
You know, there's one fracture that wasn't discussed, and that's the transphyseal fracture that occurs more in the younger patient. And often that can be confused with a lateral condyle fracture. And I think it's important that we discuss the difference in those. In the lateral condyle, the condylar roxus radius alignment is displaced, but in the distal physis, it is maintained. And if it's a distal physis injury, it's just like a supracondylar. You can just do a very simple closed reduction and pin fixation. So that's a fracture that often is unappreciated, and maybe we need to think about that and always remember that you can have a total transphyseal fracture. One other rule I think is important is if you have a medial epicondyle fracture in a child that's less than 10 years old, that's before you have the ossification of the medial condyle. And if you have a medial epicondyle before 10 years of age, it's a medial condyle until you prove it otherwise. And the other thing I think that you need to understand is that sometimes you can get avascular necrosis of the trochlea. And of course that's due to not to the treatment, but to the type of fracture it is. And so if you have very distal transphyseal injuries, you need to warn them that you can get avascular necrosis. And the same thing occurs with very, very distal fractures of the supracondylar, because that will disrupt the blood supply to the two ossification centers of the trochlea.
If I can also, if I can add one, sorry, if I can just add one more injury to this list of other things that we didn't talk about, it would be the intra-articular radial head fracture. We talked a lot about radial necks, but every now and then you'll have a piece about a third of the articular surface of the radial head come off. And those go very, very quickly to instability and terrible arthrosis unless they're fixed. Those are really bad problems that you don't have a good answer for later. And so I have a very low threshold for getting an anatomic reduction, even with open reduction and even screw fixation across an unossified epiphysis to make sure that you have good stability and anatomic union of a radial head fracture. That's an uncommon but a very, very bad problem in young children.
Rroger, in that case, do you also have to repair annular ligament when you fix the radial head fracture with a screw, or you don't? You will assess after fixing the head?
Yeah, so if it's really unstable, I typically don't try to tighten too much the annular ligament, and I won't do an annular ligament reconstruction either, because that will take away their pronation. I have in those circumstances used a radiocapitellar pin into the intact part of the radial head and then fixed the articular fragment to it, but using quite a big pin so it doesn't break, and putting it obliquely through the radial head so that it comes out the radial neck in case you need to fish that piece out later.
I just had one other question. Like, I've seen reports and I've also seen people talk about lateral condyle fracture with an elbow dislocation. And I think that if you have a big enough piece that is fractured, the elbow is going to be unstable. It would look like it's dislocated. So do you think that there is a separate entity where there is a lateral condyle fracture with a separate elbow dislocation? Because if you have a big enough piece going all the way medial where the more than 3/4 of your articular surface is off, it is going to be unstable. It is going to be dislocated joint.
Yeah, you could perhaps have two independent injuries and where the radiocapitellar joint is disrupted as well. But I think the point that you make is very valid, that when you have, especially if you have internal rotation of that lateral condyle fragment, you can have a dislocation of the trochlea anterior to the coronoid. And it's really just fracture displacement more than a completely separate entity. But those are the two malunion cases that I showed. That was exactly the case. The trochlea was in front of the coronoid because the lateral condyle was rotated 90 degrees internally, and that took the entire elbow joint with it.
So, Premal, can we end this questions here? It's almost 9:04, and we've had this session for 2.5 hours, and we could go on and on because almost 50% of the cases we could not discuss. We couldn't discuss medial epicondyle, and we couldn't discuss elbow dislocation with medial epicondyle fractures, and we couldn't discuss cases which Dr. Wilkins mentioned about. But it's always, in India we say it's always better to depart when there is something more has to be looked up. So we need to look up to, and I'm sure we can have one more session of elbow injuries in children sometime in future with all these things left behind. So Sandeep, I would request you to close this session, some of the information about tomorrow's session, and then we can say goodbye.
Yeah, so at the outset, let me thank Professor Wilkins for joining us on this panel today. It's always an honor to and Dr. Rroger Cornwall and Eric Edmonds for those pearls of wisdom. I think the take-home message for the audience, which is still there, about 140 people, should be that lateral condyle, it's essential to find out first whether it's stable or unstable. And that depends on a good internal oblique view. That is very, very important to find out the exact nature of the fracture and the exact nature of the cartilage hinge. If in doubt, additional investigations like arthrogram, ultrasound, or MRI will help you. And fixation will go a long way in preventing non-unions, because as the cartilage hinge, if it is broken, the extensors are pulling at it and synovial fluid is seeping in. So they do tend to displace after 8 to 10 days. If you don't have the facility of ultrasound or MRI, call them back after a week for a check X-ray. But when you do the check X-ray, please take it outside plaster. It won't displace as easily as you think it would. Or if it's a fiber cast, you can take a very good X-ray through the plaster itself. So document every lateral condyle till it radiologically unites. Compression screws score over pins, but you need a large enough metaphyseal fragment. Don't try to go across the growth plate with a compression screw and add to the damage. If you're going to put pins, make them go divergent and make sure that they are bicortical, and remove them quickly enough in 4 to 6 weeks to prevent any long-term infection from the pin track sites. The trash lesions around the elbow are multiple. You need to read about them. Read the original article by Peter Waters, which has been put on the Telegram group, so that you know the variety of trash lesions that can be there. All of them are usually intraarticular, and all of them usually need surgery. So have a very low threshold for further investigations like MRI or CT scan. Document them properly. Late presenting cases we have seen in our country where massage and some tight bandages have been done are prone for complications, especially myositis. So it's best leave them alone if they are more than 10 days old, rather than iatrogenically causing a totally stiff elbow and getting the credit of creating that, rather than leaving them alone and treating them later for the complication that they will come to you with. I think we'll have a great session on forearm fractures tomorrow. We still have to talk about lower end radius and radius ulnar fractures. 6:30 tomorrow. So we'll again meet at 6:15. And I thank everybody on the panel, Sheetal again for his pointed questions and pearls of wisdom, and all my Indian counterparts. Thank you and good night, everybody.
So before we part, please go through IFICS Treasury. The past sessions are on there, and very beautifully made videos by our Indian faculty, which are summary of all these lectures, are also on IFICS Treasury. So with this, good night and see you tomorrow. Thank you, everybody.
Thank you.
Good night.
Bye-bye.
The cases are really good because a lot of the points are driven during the talk. So I think keeping less, because when you skip these cases, the audience may be interested in looking at them. So it's better just to have a shorter PowerPoint and keep additional cases as a separate PowerPoint in case you run out of time if you want.
same type of case should be preferably avoided. Everybody has same kind of case, so pick only one of each.
Absolutely.
Are the participants able to listen right now? Or
They can listen. They are on their way out.
Yeah, almost everyone is living.
Yeah,
just wait for
57
5
people
minutes.
are still there.
I think as Dr. K. Wilkins noted, I think if we keep on asking foreign faculties about delayed presentation, I don't think they're going to get a great answer from them. They don't see all these things at all. So I think asking them questions. What is your suggestion, Sheetal? How much
I think
contribute to delayed presenting injury?
we only spend like 5 or 10 minutes on those, so I don't think that we spend too much time. I think it would at least let everyone know what the problems are, how problems are different in different areas. So I think it's okay to just do a couple of cases like we did lateral condyle. That was perfect, to see different options when they present late. And probably the Indian faculty can educate everyone more than the foreign faculty when it comes to late presentations, myositis, stiffness and everything. Since
I think we spoke on that in supracondylar session, Sheetal, quite well.
What is that? Yeah, and the other thing is that Dr. Wilkins mentioned that we didn't talk about transfiscal, but we did talk about transfiscal in the supracondylar session.
Yeah,
Here we did not have enough time to go with the trash lesions and the radial head, which Rroger pointed out issues with it. So that's great. And I think what other fractures did Dr. Wilkins said that we didn't cover was
medial condyle, he said medial condyle fracture. But it was mentioned, medial condyle was also mentioned.
Eric showed a really good example of what can mimic, what can appear to be a medial epicondyle and was truly a medial condyle. But it's so rare that it's okay not to, have a separate, case discussion on it. I think the important point is just diagnosis, and then, people can look it up because it's a rare injury.
So tomorrow is going to be another big day, forearm fractures and distal radius and hand injuries. So I think we will be able to finish by this time itself tomorrow.
We have kept less cases. I think 4 cases, 5 cases in both the discussion. Distal radius,
so
5 cases.
Montage, we'll have to have a separate session. It's an important fracture.
Was supposed to be today or tomorrow?
Today, but James had some, he had a difficulty, so he's just requested for it to be done later on. So, and with all this plus Montage, would have extended. So in a way, it was good. We couldn't have that because then these questions we would not have been able to discuss.
I thought that we can have a maybe another bonus or add-on session at the end, if time permits or if we are up for it.
Okay. Then I think we had a nice day on the whole without any glitch.
We don't need any questions to be answered, right, from the delegates. I think all of them were covered.
No, I think we took almost all of them. There were a few repetitions, but I think we have answered everything. But Taral, that saves some time for tomorrow's session, I think. Then tomorrow, hardly we have any questions which are not answered.
Right. So tomorrow we don't have that. Tomorrow what we do is initially we have some announcements and then there is no quiz also tomorrow. So we can utilize that time initially to maybe, the history of IFICS. Sandeep, you want to do that tomorrow as the delegates are joining?
Very easy, I don't see.
अच्छा मैं बात करता हूँ संदीप से चल शीतल
okay all right
okay good Bye.